Hi, good morning, everyone. Thank you for coming to our AEG Interventional EUS workshop. We have a busy program ahead, and I think people are still coming slowly, but we have to start because otherwise we may not end on time. And I think Anthony has a flight to catch as well. So welcome to our workshop on optimizing success in interventional EUS. We decided to organize this workshop because we felt that there's this unmet need. I think right now in most places, people probably can get adequate training in diagnostic EUS, in EUS tissue acquisition. But the challenge is how then do you go on to the next step in terms of doing a therapeutic procedure professionally, confidently, and ideally it's best if one had enough case volume and also an expert to be on hand all the time to take you through, but that is not reality. And in that case, then we have to find ways to help our community raise their level and practice better. And that's why we are organizing this workshop, and I'm very happy that we have both an excellent cast of experts who have come to share their insights and provide some practical tips based on their years of experience. So I think without much ado, I'd like to start the meeting. I think the first speaker is of Andrew Kwek. He's from Changi General Hospital, Singapore, and he will share with us his insights about how we can optimize success in EUS-guided tissue acquisition. Andrew.
Hi, good morning from Singapore, and thank you for the introduction. So we'll quickly go on to the first lecture, which is on EUS-FNA, FNB. Okay, so we know that the EUS was first introduced in around the 1980s, and FNA was subsequently as a natural progression in 1990s. And you can see how initially on animal studies, initially the EUS scopes were quite rigid, so quite challenging compared to what we are doing now. But the main issue has not changed over the decades, and tissue acquisition, tissue adequacy remains paramount to what we do when we do EUS-FNA. So some of the considerations is whether FNA is the right thing to do, what type of needles, and what are the evidence-based techniques that can help us optimize the success. So these are some of the indications and contraindications that practitioners would know. Typically, we want to do a diagnostic procedure that has high yield, but it needs to be safe. So informed consent is important, optimizing the patient, making sure that we minimize and mitigate risks. So in today's lecture, I'll talk about technique, types of needles, what are the diagnostic accuracies, methods to improve, some of the adverse events, and how do we optimize the specimen preparation. Okay, for technique, because the scope may be straight and may be angulated, it may be a bit complex. And then because, let's see. Okay, the video doesn't run, but okay. But anyway, the scope within the duodenum, we have to be a bit aware that sometimes when the duodenal junction is a little bit more angulated, the scope will be twisted, and sometimes the needle will be difficult to come out. So we may want to use a slimmer needle. We may want to use a appropriate scope. Lesions that are solid versus cystic also have special considerations. Not all cystic lesions need to be punctured, especially if they're in the mediastinum and they look benign. We always do Doppler to assess for vessels and try to avoid puncturing through larger vessels. Sometimes the smaller vessels may be punctured, but still I try to avoid it usually. And we need to align the lesion to the path of the needle and avoid excessive scope tip elevation. So the FNA needle has pretty standard components given from different brands and vendors. They have a hollow needle. There's usually a solid removable starlet and a protective sheath. And then there's a handle. So these are the typical shapes that we find. The non-biopsy needles typically called the Mangini needle tip. And then there is the reverse bevel and forward bevel Westcott. The biopsy needles that will be either Francine, fork tip, or if you're from the Procon needles, then it'd be the bevel needles. There are various sizes, ranging from the largest being about 19 gauge and the smallest being 25 gauge. Now, people have compared the tissue diagnostic accuracy and the ease of puncture based on the different types of needles. And usually the Francine and fork tip type of needle tips have the best tissue acquisition rate. There are some newer needles, for example, from Olympus, not launched here in Singapore yet. It's called the Secure Flex. They have a dual bevel raptor tip. We don't see much studies on this yet, so look forward to that. Cook launched a few years ago their Francine tip ones, and Boston has their Acquire. And of course, there are also many other newer needles from Microtech and others. Okay, in terms of needle sizes, for solid pancreatic lesions in the head and uncinate, which is typically a very challenging mass location to obtain tissue, it's advisable to use the slimmest needle, which is a 25 gauge needles. It tends to slide more smoothly and you'll be able to get more tissue. So for pancreatic masses, we typically use slimmer needles. In terms of puncture method, there is the fanning method, which is standard, where you fan through the mass and try to position the needle through various parts of the lesion. And it's been shown to need a lower number of passes. For small lesions that tend to be displaced with the needle, especially if you use a larger bore needle, then you would need to do the door knocking method, where you use a rapid inward movement into the target lesion, which minimizes the tissue displacement. Yeah. In terms of whether you need to use suction, typically if you use a biopsy needle, you'll need some negative pressure. Whether you use it with air suction, say, air suction or wet suction or slow stylet pull, well, it may increase the tissue yield. Also have to be careful with blood contamination. So for example, for lesions such as lymph nodes, they tend to be a bit more bloody. You may want to sometimes not use too much suction, and the slow stylet pull may be good. But suction does improve diagnostic yield in fibrotic lesions such as pancreatic cancer. There's this method called the hydrostatic starlet technique. This was introduced a couple of years back, where they use the water column within the needle and combine that with the starlet that is move very slightly as they puncture through the mass. So this has shown to have actually improves the sample adequacy with lower blood contamination and needing fewer passes. But I think we need to see more studies related to this. Whether to use a starlet, it does provide some stiffness to the FNA needle, and and certainly does prevent clogging of needle of tissue within the needle. But typically, it has no great benefit. So whether you want to use Starlet or not, I tend to just use it for the first pass and subsequently do without it. So when you compare between Starlet retraction versus suction versus no suction, it's also relevant to look at what type of needle you use. So if you're using a Francine needle, for example, Francine biopsy needle, it's been shown that Starlet retraction is pretty good technique to combine with it. And then there are other methods to improve diagnostic accuracy. So depending on the size of the lesion, where the lesion is, the door knocking method, the number of punctures should be considered. For solid masses, we typically would now use FNB needles as a default. FNA needles does not have a very good diagnostic yield most times. For ancillary studies, most of them may help to improve your confidence of what the lesion may be like, but still is typically not diagnostic. So usually we still want to get good yield and good tissue. So for challenging cases, you may want to have presence of a cytotechnician or cytopathologist on site to help you with the diagnosis. If your center has the service, then you can also employ liquid-based cytology as well as send the tissue for further studies. Now, some adverse events, the standard communication that I give to patients is 1% risk of complications such as infection, bleeding, for pancreatic punctures, acute pancreatitis, and less frequently complications such as bowel leakage and perforation. For tumor seeding, we try not to FNA patients with suspected cholangiocarcinoma CA if they are surgical candidates, because that may push them away from being a transplant candidate because of the risk of tumor seeding. So to reduce complications, all punctures or cyst lesions, we have to give antibiotic prophylaxis. So all those pancreatic cysts that are suspicious and you want to puncture, do give them the appropriate intravenous antibiotics. We always check coagulation panel if they may have a history of bleeding disorder or for example, liver disease. Try to avoid FNA in patients who are on oral anticoagulants or triclid or Plavix, and so avoiding FNA or cystic lesions if they are antithrombotic agents. Decades ago, there was a device that could do true cut biopsy, but it's gone out of fashion because there was a high complication rate for perforation. So nowadays we don't use that true cut biopsy device anymore. The last part is about preparation of a specimen, which is to me is equally important besides all the earlier part of techniques to improve the FNA or FNB, because if your specimen is not processed properly, you're not going to get a good outcome of having a diagnosis. So when we look at FNB, we really want to get the tissue core. And how do we recognize the tissue core? It's a very tan, very pale looking material. And here, for example, there's quite a bit of blood clots, but you can see that there's some pale core tissue within it. And if you can separate out the blood and just put that into formalin, put the tissue into formalin, that will help process it further. So for cytology, the main aim is to have a monocellular level, monocell layer. So we need to have a smooth smear spread so that it doesn't cause any damage or trauma to the cells. If there are some tissue fragments on the slide, we pick it off and put it on a filter paper, and that is then placed into the formalin bottle. Sometimes after a puncture, you don't see any tissue fragments, and I typically would just do a further puncture and just shoot everything in that needle into formalin, and that is then sent for cytospin so you can process it as a cell block. Wet fixation means we preserve the slides and the cells in alcohol, and usually we'll tell our nurses to do it almost immediately so that we don't see any drying artifacts. Typically try to work with your pathologist at your own center to employ the best practices. Okay. And then there's this consensus statement that was just published a few years back from the AEG group also. So you can look up this paper for further advice and recommendations. So in summary, FNA and FNB, so we normally just do FNB for solid lesions now to improve the yield because the needles have evolved, and it's kind of like our default needle now. Do the procedure when indicated, and make sure the patient is optimized, choose the right needle, right technique, and prepare the specimen well. Thank you.
Good morning, everyone. I'm Lai Mun, and I'm a GI pathologist, formerly working here at Changi Hospital, and now currently working at Parkway Laboratory Services, a private laboratory. And after a great talk from Dr. Andrew Kwek, right? He has covered all the technical part of it, and I am really amazed at how the evolution from just FNA cytology, where the pathologist will be quite happy to just, atypical cell scene, don't know what's going on. Okay, just blah, blah. You don't really have to be too good in cytology. And that's the thing about training as a pathologist. There are fewer and fewer pathologists who like to do cytology, so it's harder to find a true cytopathologist these days. And that's why there's a push towards FMB, and you'll actually have some idea about the talk throughout about what you can do with cytology specimen. Okay. So what defines success, right, is really adequacy. So adequacy in the past is success, right? I'll be very happy. Everyone will be happy. Oh, it's cancer, it's a neuroendocrine tumor, or suspicious for neuroendocrine tumor. But these days, there's a push for confirmation of diagnosis. They really want to know is adenocarcinosis. They want to confirm it's neuroendocrine because the management is completely different. And on top, so you need immunohistochemistry. So that's part of diagnostic. And certain diagnostic, even ancillary tests, right, that changes the oncologist's decision for their management will be things like mismatch repair proteins and PD-L1. They really need good tissue core for immunohistochemistry. Then the third part will be the molecular, which is NGS. So things have changed. In the past, it's just diagnosis is enough. Now we need more and more because of the demands and expectation from our oncologists. So adequacy, of course, by our endoscopist technique, all of you here. And that's the purpose of this workshop. In the afternoon, you kind of upskill a bit, right? And for the pathologist, is really just to, for those working in very good centers, you have great tissue to work with. That's all I can say. Okay. So, I've also mentioned earlier on, so the part of the talk is actually on if you only have FNA and some lesions, right, I must say, and due to the technical difficulty of its location, somehow FNA, the cytology is what you get. And then when it comes to core, especially like certain very paucicellular adenocarcinoma of the pancreas, somehow you just don't, you get the only the collagen, the stroma, but you don't get the tissue shell, only get 1 or 2 cells. And strangely, then you get where you're actually in the soft tissue, you seem to have a lot of the extra, what you call pancreatic tissue that may have captured all the cytology. So please also continue to do aspiration if you can at the time. And then also do, of course, now everyone is moving towards FMB. So for the cytology, if you have rows set up, most of the endoscopists would like to have that presence, or the luxury to have it is to have spread direct smear with in the presence of a rose support. But if not, like in Changi, I think most of the endoscopists are very well trained by Andrew and Ting Liang here to do their own spread as well. And they would actually have the direct spread, which is usually PAP. If you want to do diff quick, that's with the rose, then they can give you some idea what sort of tumor it is and the adequacy. And then certain centers, they don't do the direct smear. They actually concentrate everything to make it a cytospin. So all the cells go into a little palette. It's easier for the cytopathologist or the pathologist to look at them. And liquid-based cytology is something mentioned in Andrew's talk earlier on, and that is actually more expensive because you need a special cytolite to keep it. But it's very good in removing all the debris and all the blood. And it provides very good cellular information. So like cross chromatin to actually push for malignant diagnosis, actually liquid-based cytology is very good. I would say like biliary brushing is very good, but from FNA cytology, right, it does not actually have anything, it's not more superior ultimately. Then the last thing, if you do not have rows and you're not very good in spreading slides, right, there's a push also to actually just put everything into formalin, and then you make a cell block out of it. The beauty, the advantage of having a cell block is that it's formalin fixed, and then you can run immunohistochemistry directly on it. If the FMB part of the specimen is inadequate, or you have run out of tissue to run on, and because it's actually processed in the same way as a tissue, so it will meet all the validation, right, for all sort of immunohistochemistry tests or NGS requirements, okay? So direct smears, again, to repeat, is rapid on-site if you have it, the luxury of having it. The experienced one not only tell you the adequacy, but can give you an idea of what tumor it is that you're dealing with. And so, take some more, I will need a lot for immunohistochemistry, or maybe I will need NGS later on. So, but this is falling in demand in Changi here from probably because of the very experienced endoscopists on site, and also the lack of cytopathologist support. This one is actually, in most centers, is actually not, they do not have rows. And also all the good needles that you have seen, all the very good technique being taught. So it's actually a less demand for rapid on-site, and it does not really have it's not more superior in terms of getting achieving adequate tissue for diagnosis and ancillary studies. In fact, this one is better for it's only some endoscopists who are trained, depending on centers, they still like to have the reassurance that from the cytotechnologists to help them. So based on your own individual preference, ultimately. So this slide has been covered by Dr. Kwek already, Andrew, on how to prepare your palette and then pick out all the tissue core and then put inside your formalin immediately. And then if you're doing a direct spread, right, please, if you're not doing on-site, you can put everything in fixative, to avoid all the air drying artifact and also to preserve the quality of the cytology specimen. With modern NGS technique, if your tissue on your FMB is inadequate, with a lot of cytology material on your direct smear, you can still, and if it's well preserved in terms of quality, you can still send it, work with the molecular lab, right, and still run your NGS on direct smear preparation. So this is covered, all this here is cell block. So there's a preference by most laboratory or pathologist. Okay, it has the same advantages as a tissue block. And so if we do not have rows and no support at all, it's actually just to put everything you've aspirated, right? They aspirate directly into formalin or some liquid rich. And then the cytology lab, right, will actually be good enough to actually just concentrate it and create a cell block. And everything will be processed. And even if you don't have a cytopathologist, an ordinary histopathologist will still be able to interpret it with up to pretty good standards, actually. Yeah. So now, how to optimize your report, especially for challenging cases? Please engage a specialist in GI pathology or specific site. If it's a lung metastatic lung to an unusual site, also you can actually get a lung pathologist as well. Okay, and then I have a special interest also to understand what sort of lesions we're dealing with. Since this talk is about solid, so the examples I'm going to show are all based on solid lesions, and some discussion, especially for those like pseudo tumor, it's always good for the pathologist to discuss a phone call or WhatsApp to discuss about difficult lesions that you think might be a pseudo tumor rather than a true lesion, to actually understand whether we have actually got diagnostic material on the specimen, and it's to actually improve the yield of a good quality report at the end of the day. The adequacy for solid pancreatic lesions here in Changi is still is very good. It's over 95%. And just that on the topic that we have been covering about 25, all the different sizes, Procon needle, right? So this is an example of a Procon needle. A little pallet is 0.3 cm, maybe tiny, but it's the size of all those endoscopic biopsy, mucosal biopsy. And look at the glass slide seems a bit blank, not much material, not too bloody. Doesn't mean it's bad, okay? For this lesion, you can see on the 0.3 cm, 3 mm little pallet, you can actually have so many cells. So this is actually adequate. If you need NGS, this will fit, is adequate. And this is all very similar. It's monomorphic, some pink cytoplasm around, and it stains with chromogranin and synaptophysin. So Ki67 is actually less than 3%. So you can actually get very good report these days. We are dealing with a grade 1 neuroendocrine tumor. Now, this is a mimic for neuroendocrine tumor. On cytology, this was a private practice case, right, that has row support. So you see there's guaranteed adequacy. And, oh, hang on. Good FMB material, and then it's also small cells. So for the first run, right, I usually try to preserve my tissue. I won't cut so many, and then you're just wasting tissue ultimately if it turned out to be something unusual. And this was one of it. The synaptophysin and chromogranin were negative. Ki67 I know is a low proliferating tumor. So then you have to think about the mimics, which is solid pseudopapillary tumor of the pancreas, which is positive for beta-cat and CD10. So you do need to actually go in stages. And that's why a good specimen is actually quite handy for second or third round for challenging tumors, difficult ones. And this is a 20 gauge Procon needle from taken from a stricture from the upper esophagus. This is give you better good quality 1 cm specimen, and the smears are actually quite good, as you can see, and confirm on the microscope to be some sort of adenocarcinoma with some mucin here. And the core biopsy is not only shows, it has picked up some muscle as well, native muscle muscularis mucosae, and higher magnification confirms adenocarcinoma with the mucin blob and then some gland formation. Now, it's unusual to have adenocarcinoma in the upper esophagus. So you have to actually screen for metastatic. So we do all the whole panel for adenocarcinoma, which is TTF1 is quite specific for thyroid or lung cancer and together with the combination TTF1 and epsin positivity, is consistent with a lung primary to the upper esophageal region and the cause for the stricture. Now, this is FMB taken from the 57-year-old man who initially presented with some mild dyspepsia. OGD EUS performed initially was normal. Then 3 weeks later, very suddenly developed this obstructive jaundice, went in for EUS with FNA, and then stenting performed as well. This is actually one of Prof. Ang's case. You can see the core is actually, because it is, you can see there's some blood and fibrin in the background and nice good cores of recognizable pancreatic tissue. But I don't see any tumor cells, but it's such a good core that you can actually appreciate the background, the normal pancreatic acini, as well as the inflamed areas. And the inflamed areas, you can even see is mostly plasma cells. So you're dealing with some sort of pancreatitis pseudotumor, okay, that is mimic for adenocarcinoma of the head of pancreas. And IgG4 and IgG fits the criteria and suggestive of a type 1 IgG4 related autoimmune pancreatitis. And this is confirmed with serum IgG4. And the patient was started on prednisolone and have a good resolution resolved on the following MRI. Now, this is the second case, 54-year-old man with gastric outlet obstruction. I was there in the endoscopy room, right? Because it's an unusual case. So the MRI and CT actually confirmed there's a pancreatic tumor mass, but on endoscopy, ultrasound, the mass was actually not very well defined. I was in the room and I can see how the needle have gone, whether it's the knocking technique or double tap, right? It is really in the lesion. So for the pathologist, I am also quite confident that it is in the lesion, but the smear I get was actually not. I cannot understand why the smear is just like very dirty. So you think, is it necrotic tumor, debris? And then there's some atypical cells. So it's a difficult lesion. So I just say atypical cell seen. Tumor cannot be excluded. So I waited for the FMB. And the FMB actually just showed normal pancreas. So when you put the two, and the IgG4 is actually completely negative, so there's no. So to put the two together, what you have the cytology, where you can see what you will call the granulocytic epithelial lesion, right? GELs. So it's actually useful to know that the lobules, which is for IgG4, they attack the lobules of the pancreas, whereas for type 2 pancreatitis is more ductocentric. So that's why you get normal looking pancreas in the background. So this was how the diagnosis of type 2 pancreatitis was made. Patient was also started on steroid and completely recovered. So finally, back to what I haven't shown so far. This is a 20 gauge Procol needle, good 1.5 cm core, demonstrating adenocarcinoma. Cytology is sparse, but we're so lucky to have a good core these days, right? That you can make invasive adenocarcinoma quite effectively. And now the pressure is on you guys to get adequate tissue. And because the oncologist will say, oh, I need this test, they need like definitely mismatch repair protein to start. If it's actually lost or MSI unstable type, right, or deficient in mismatch repair protein, they can actually be selected for pembrolizumab for advanced tumors of any site at all. Okay, so they will actually consider starting on immune checkpoint inhibitors for all deficient in mismatch repair protein. And then now, of course, you have heard of the PD-L1 and then Claudin, which all will be very useful for advanced tumor of any site at all. And question always asked, right, for this is how much do you need to call it adequate for NGS these days, right? So from the tissue core, I need about 10 to 20%. And also depending on the type of platform you're using and which lab you're sending it to. And I've mentioned about the direct smear that you use. Like in the past, people say it's not possible, but now actually with improved technique, it is possible. And you actually can use, as long as there's about 100 cells, you can actually send it for NGS. So that's very desperate. You don't have to repeat the procedure again. The only thing is you have to make sure that the quality is good. So 100 good quality cells will still give you a very satisfactory NGS results ultimately. So now I've come to the end of the talk, and you understand how, like, if you do not have rows, you don't do cytology here, but you have got a good aspirate, just put it directly into formalin and say, please prepare cell block, okay, to the cyto department, and then adequacy, right, is determined by the endoscopist, and now with better techniques, so just need to keep upskill yourself, and then the pathologist will love you for sending all the very good quality specimens. And here, thank you for your attention for my talk. Thank you very much.
Okay. So some time for question and answer. Are there any comments or questions? Yes, Tifa, right?
Yes,
Okay.
I just have a question.
Passing the mic.
Thank you for the talks. I just have a question. In today's day and age, do we still, is there a role for the 25 gauge needle, or should we be, as much as possible, minimum, try to go use a 22 gauge, in view of, there's more tests, and we need to, we need adequate tissue. Thanks.
In practical, I normally would try the 22 gauge needle first. But sometimes when I find that if, for example, because of the duodenal loop and the scope passage is difficult, the needle doesn't come out smoothly, right? The tissue yield tends to be quite poor. Then I may switch to a slimmer needle. And be surprised also that even a 25 gauge biopsy needle, you can see small tissue cores that can be obtained. Yeah. There may be some practitioners who like to use the 20 gauge or even 19 gauge biopsy needle. But I find it's maybe a bit stiff. Yeah, especially if you're doing lesions in the pancreatic uncinate or head region. Maybe if I can ask Lyman, now with so many ancillary studies, you mentioned NGS. What is the basic ancillary study that a pathologist would do, for example, for a pancreatic lesion, and when the tissue is very little and you may not be able to do too many studies, and how we as endoscopists can help you with it?
I think I've actually covered earlier on, so right, to actually, if there's cytology in the aspirate, also make sure that it's well preserved. Because sometimes you can actually work on sacrificing it to run some immunos if it's very desperate situation, and you have to work with the lab. But it is only useful if it's positive. But it's negative, it may be because it hasn't been validated to be run on cytology preparation. Because I've used it once or twice for neuroendocrine tumor, and it looked like neuroendocrine, and you need to prove it, right? And you actually have to sacrifice it. That means after you run your immunos, you do not have any proof anymore. So if you have 2 slides, you will sacrifice one for your immunos. It's only useful when it's positive. So in such case, usually the pathologists are quite good in, so that's why I only run one. It does slow down the diagnostic process. People want like results almost like the same day or the next day. So for difficult tumors, I do not tend to run all of them. I will still be stage 1, level 1, and then if it's negative, like the solid pseudopapillary, then okay, it's negative, then I run the second time. So a good pathologist ultimately is still important to how to preserve. But if it's a straightforward diagnostic pancreas, so knowing that pancreas is the only origin, site of origin, right? There's no need to consider metastatic breast or metastatic gastric tumor to the pancreas or something like that. Then you can go straight directly for your mismatch repair protein already. So you're actually saving so good clinical information. And then you then run selectively for all the oncology interested markers that will help with planning for treatment.
Yeah. Okay.
So now we move on to our next speaker, Dr. Anthony Teoh from CUHK. He's a world-renowned expert in interventional EUS, and you share with us how we can actually optimize EUS-guided radiofrequency ablation.
So, good morning, everyone. It's good to be back in Singapore. Thank you, Ting Liang and Andrew, for their very kind hosting. Sorry to be here for a very short period of time. I'll be sharing on the use of EUS-RFA. So, just for a quick question, anyone doing RFA here apart from Rusty? Okay. So I think definitely something very interesting. I think Tay Wang is here today, so I'm not sure if we'll get to the chance to try later this afternoon. Yeah. Okay. Okay. There we go. Okay. So optimizing outcomes in EUS-RFA. So actually, I think RFA comes into a group of procedures, EUS-guided intervention. You can call it injection therapy or needle therapy. In terms of injection therapy, I think most of us are more familiar with the celiac plexus ablation, variceal ablation, or even cyst ablation. But for EUS-guided tumor ablation, also a lot of interest. More people are doing alcohol injection for neuroendocrine tumors because it's relatively more simple procedure, and the outcome is more expectable, and the risk of adverse events is also lower. Radiofrequency ablation has been investigated by quite a few researchers. I do it sometimes for selected patients. And of course, fiducial marker insertion has been done in some patients for pancreatic cancer as well as histology cancers. In terms of agents used for EUS ablation, tumor ablation, alcohol and chemotherapy, paclitaxel has been described a lot. RFA is the more recent candidate. Microwave is still under investigation. So this is the microwave needle. It's under Creo Medical. In terms of OncoCell, it's actually a liquid form of radiotherapy. So it is the injectable form of radioactive liquid. So with one injection, it provides 100 grays of radiotherapy, and it can be a candidate for to substitute a radiotherapy. Any chance you can increase the no, just turn off the panels. You put it to the side. And tab. Okay, EUS-guided tumor ablation. So I think it is important to remember alcohol is still a much investigated candidate. Its first description was actually in a patient with a insulinoma, 78-year-old lady, recurrent hypoglycemia due to insulinoma, and then a small hypoechoic lesion found in the pancreatic body. 8 ml of absolute alcohol was injected and no further hypoglycemic attack was observed. So in this report, they mentioned after the ablation, which is this line, the glucose has been maintained at a fairly stable level. So I think for insulinoma, it works because the alcohol causes ablation. You don't need to have 100% ablation. You can just have 90% or 95%, and then already it provides a symptomatic relief. Thereafter, there have been many reports on insulinomas, particularly because they are actively secreting and get a response of the ablation just by observing the patient's glucose levels. So 14 articles, 27 patients with 31 tumors, mean size 13 millimeters, mean ethanol volume 0.8, 5 cases of AE were mild and self-limiting, 1 was severe AE due to bleeding from DU at the puncture site, and all cases had ablation leading to improvement in symptoms. So very good outcome in terms of a simple procedure. So it's important to remember about this because sometimes we can be very involved in new technologies. So in terms of the technique, it's very similar to a EUS-FNA procedure. So EUS-FNA is the basis for all these. You need to have a good technique of linear examination. So in this patient, 1 cm non-functional hypervascular lesion in the neck of pancreas. FNA shows neuroendocrine tumor. And then this is the image, pathology image. And on EUS, sometimes these tumors can be very vague. So you need to observe it slowly and see the tumor. It's usually quite hypervascular. So you can see on Doppler, it's quite vascular. It's common to perform contrast sonography injection for these tumors as well. In this case, I did it. So I went ahead with the ablation. The needle goes in, and then you just inject alcohol. And usually, once you inject, you can see a sort of a cloud of fluid surrounding it. I was being careful not to inject too much because, of course, the adverse events, most feared adverse events is pancreatitis. So we try not to inject too much. And then again, we use a fanning technique to cover the entire tumor. You can see this white cloud after injection. And always try to stay inside the tumor so we don't overablate it because once you're in normal pancreatic tissue, if the material is in the normal pancreatic tissue, then there's a risk of pancreatitis. So in terms of the puncture, it's just very similar to FNA technique. So 6 months later, we repeat the EUS. You can see the PD here. So it's just a very small remnant over this area. No vascularity. And on CT pre, there's a hypervascular lesion here. Post, not so well seen anymore. And in terms of long-term outcomes, 34 patients with follow-up more than 3 years. Mean diameter originally was 10 millimeters. A complete remission, 55% initial ablation, and if you repeatedly ablate it, it can be up to 70%. But EUS-0 shows reduction of all tumor, no local existing recurrence. So alcohol is definitely effective and safe with durable results. But of course, I'm here to talk about RFA, so I will explain a bit more. So RFA is a radiofrequency ablation that uses electromagnetic energy to induce thermal injury. So you are generating heat because a necrosis of the tissue. So it can be monopolar or bipolar. Later on, when you play with the needle, you would see there's a internal cooling system. So there will be tubings connecting the needle to some cold water. There's a circuit running through the needle, which helps to prevent creation of some charring in the tip, which prevents the transmission of heat. So radiofrequency ablation in pancreas was not a very hot, popular technique. So because we are worried about necrotizing pancreatitis, so in the very early stages, 2004, surgeons used this technique in open surgery. So 2 patients with multi-pancreatic metastasis were treated with RF destruction. However, 2 patients had postoperatively severe necrotizing pancreatitis with life-threatening hemorrhagic complications. So very significant complication. Another report, 2006, mortality rate was 25%, 4 out of 16 in the 4 deaths. Tumor were located in pancreatic head 3, had tumor close to the portal vein, died suddenly of mesogyl hemorrhage on 4th and 30th and 40th postoperative day, and 79-year-old patient died of acute renal failure. So sounds very scary. But you have to be aware the needles that surgeons use were very different. So you have seen all these umbrella type of needles. They're actually mainly used for liver. So they can create a big area of necrosis. So up to like 3 centimeters, 4 centimeters. So these needles probably too big for the pancreas. So as a result, for endoscopists, I think we looked at the potential of creating newer devices. So with the needle, the circumference of active heat ablation is around 1 centimeters. So in early animal studies, it was shown to be effective. In terms of RF ablation, you have to be aware it's by diffusion. So the highest heat is around the needle. And from the needle outwards, from here on the side, the heat is generated is less. So there may be less ablation around the side of the needle. So on the right is the microwave. The microwave works different. So if you put something into your microwave, the whole thing becomes boiling. It works on your water, so every water molecule vibrates. So the energy is more equally distributed. So again, showing you the needle. Close to the needle is a highest heat, around 60 degrees. If you go further outwards, the heat generated will be less, meaning the ablation will be less effective. Okay, so it's similar to cooking a steak. Okay, if it's well done, the tumor is completely ablated. But if you go for medium rare, there's still some viable tissue below it. Okay, so this is a concept you need to be aware with the RFA. So if you are further away from a needle, then there might be still some viable tissue. So it's a balance, because in the pancreas, you cannot ablate too much, because if you ablate too much, then you can cause pancreatitis. Right now, there are two needles on the market, which are named to be RF needles. The Habib one is basically a wire, so it's not really a RFA needle in my personal view. So not many people are describing the use of it. And the EUS-RFA from StarMed or Teoh is the one that I think most people are using. And you can see the ablation zone. It's very similar to what I mentioned to you. So the inner ablation zone is most charged. And as you go outer to the outer circle, there'll be an area of medium rare or less well cooked area. The needle used to be 18 gauge, now it's 19 gauge, so it's stiff. You need to be aware of that. There's a special unit you need to connect it to. Okay, so this video is what I sent to my nurses to teach them how to connect everything. Sorry. All right, so okay, go back. So there are two electropads which you need to connect to the patient. You need to have the needle, and the needle has tubes connecting to water irrigation, and of course you have the saline irrigation. Okay, and this is the generator, and then this is the water pump. Okay, this is a needle. You can see the silver top tip is the active blade. And it's very sharp. And then you can see these two tubes connecting to input and output of the water irrigation. So from here, you can see the tubings. First, you need to attach to the water pump. There's an arrow here on the tube. Just put it in the same direction as the water pump. It goes round and round. Attach it to the tube. And then one end connects to the extension tube. We put it into a bucket of cold water. So both the input and output can be in the same bucket of cold water. So you reuse the cold water. And then the other hand connecting it to your needle. And then you have these resting plates. So two pads, one's connecting to each leg of the patient. And then connecting into the device. And then you have various modes. Most important is the energy level. This is 30 watts. And then you have the temperature as well as the impedance. Right. And then once you start the system, water will go through it, and you have to wait for the water to prime the entire needle. And then you set. So case example, a patient with a pancreatic cancer with invasion to celiac, no distant metastasis, planned for radical chemotherapy, and then decrypted to EUS-RFA. So the tumor is not very obvious, but it's over at the body of the pancreas. Again, in terms of the procedure, it's very similar to FNA. You can see the tumor is here. So you puncture with I usually start with a contrast study first. So you can see some vessels inside the tumor. And then we puncture with the needle. And then once you start ablating, you observe for the bubbles. Once you see some boiling of the bubbles in the tumor, it means it's starting to boil, then there's some ablation. And then you can pull back your needle a little bit and then have serial ablation to cover the entire tumor. So sequentially, you can ablate the entire tumor. So after you ablate it, you can do another contrast study, and then if there are no vessels inside, then it suggests that there is ablation of the tumor. So in terms of PET 1 month later, there's not much contrast enhancement. Another patient with hepatocellular carcinoma. So you can see this patient has multiple stuff done. 81-year-old, multiple recurrence, lab resection, percutaneous artery, TAC, so many therapy. And then this year again, last year again, another recurrence. So finally sent to me for EUS-RFA. So the evaluation, I think, is pretty good for RFA because you can be more aggressive with ablation. These lesions are quite small, so the radiologist may have difficulty identifying it. So there's a PET scan. So a fake lesion over the left lobe of the liver at the pointer. Is it a pointer? What is the pointer? Okay. So here at the arrow, you can see a small lesion. So for us, during EUS, we just need to be sure we can access it from the stomach. So left lobe of liver next to the stomach should be easy for us. Oh, yeah, here it is. So on EUS, actually, lesion not so small, easily seen. Very easy for our FNA needle to go through. Contrast shows a hypoechoic lesion. Puncture with the needle, so just do serial ablation. So for this lesion, I went aggressive. So I ablated the edges very aggressively so that there's no chance of recurrence. And then there was complete remission 6 months. Okay. If you look at the literature, I think still not a lot of reports. There are various indications from PNET to pancreatic cyst to locally advanced tumors. There's still no agreement on what energy that we should use, but this is at least some case series. And a larger one published from Mark Mate, mainly for neuroendocrine tumors, 14 patients, and you can see significant report response is 71%, and on 12-month follow-up, 85% for pancreatic system neoplasm. Significant response is 64%, and on 12-month follow-up is 70%. For Cheyenne's group, they used the RFA to do the trial comparing with Cineplex neurolysis. They showed with RFA group, the pain score was significantly lower. They used the Habib needle at that time. So maybe some advantage as compared to CPM. They ablate the celiac angle. I think for Pratham-Chai's study, this is most promising. 47 patients with unresectable metastatic PDAC. RFA with this trial repeated every 2 to 4 weeks until not possible. And these patients were all mostly on chemotherapy. And he showed a significant survival benefit on the RFA group. And the median survival was 13 months. Yeah, 13 months as compared to 7.7 months. So some survival benefit on the group of patients. Okay. And in terms of complications, if you don't ablate too aggressively, I think it's okay. Most patients will have some abdominal pain, but not most won't have pancreatitis. This is a patient that had an unusual tumor, myosarcoma, with metastasis to the pancreas. I ablated too much, so she had a PD stricture. You can see the PD was very dilated. She had recurrent pancreatitis. I think this is the EUS view. This is the PD. Oops. That's the PD. You should dilated PD. So a PD stricture. So just the dilated PD, and then right here there's a structure. So at the end I did a rendezvous ERCP. So in the interest of time, I won't show this. It's a complicated procedure. Just show you, we did a US rendezvous. We passed into a ablated cavity. And finally, we were able to pass the wire. There's a small bit of contrast there. And the wire through. Then we were able to do a rendezvous ERCP. Then the PD snap. Okay. So tips. We should do it under NaCLJ, lateral position, prepare ice water bucket, prepare needle and generator. Needle is 19 gauge, it's quite stiff. It's okay for lesions around the stomach, but if it's close to the duodenum, we need to be aware. You may not be able to puncture it. You may need a forward drain scope because there's no elevator, so the needle comes out easily. You need to consider PD stent if it's very close to the PD. Energy always start low. In the past, we used 50 watts, but now I'm using 30 watts, and then we go slowly. The blade until bubble seen or impedance rises. Do not overblade. Always be safe, and always remember the risk of pancreatitis. Okay. So in conclusion, RFA is interesting local ablative modality. Careful choice of patients may be beneficial, but definitely we still need more RCTs to confirm the efficacy. So happy to take questions. Maybe I start off. So how do we, you're saying that we don't overtreat, right? Which means to say, you do expect the need for retreatment. Because like when we do resection, we try to resect normal tissue. So you don't go beyond and ablate normal tissue to ensure that all lesions are affected. Is that right? Yeah, of course. So again, I think the indication is very important. So for PNET, there's always an argument whether you need to treat or not for grade 1 lesions. A lot of people thinking it's a benign lesion, you can just observe and not treat it. But of course, there is another group that are very aggressive. If there's neuroendocrine, we try to ablate it. So that always work with your oncologist, work with your surgeons, work with the patient. Some patients are very worried. even with grade 1 net, we want to do something about it. So you need to discuss with them various options, alcohol versus RFA. And if you go for RFA, so for the PNET, in general, it's more of a benign condition. So if we ablate it, we try not to cause any complications. So you do it once and try to stay within the tumor. Of course, it's persistent. You can always have a second chance to come back to ablate it again. If it's pancreatic system neoplasm, for example, if it's elderly, you see some mirror nodules, it's with the cyst, then there's a lot of cyst fluid around it, then you can be aggressive. In cyst, you can ablate the mirror nodule quite aggressively. If it's tumor, then again, it depends on where. If it's in the pancreatic head, so I think these patients in general more like a palliative situation. So you're trying to just try to provide some local control, cause some ablation, hopefully chemo works better. So again, stay within the tumor and not to overdo it. If it's lesions from the adrenal or liver, then you can be more aggressive because those organs are more forgiving. So it really depends on what you're feeling. Any other questions? Yeah, bye.
Thank you, Prof. I just have a question. Given your experience that you've done ablation using alcohol and also RFA, what is your selection criteria? Some patients do better with any one of the modalities.
So I think there's no direct comparison of alcohol versus RFA. So again, alcohol is mainly effective if it's a neuroendocrine tumor. So there are some advantages of alcohol because it's very cheap, so available everywhere. Technique-wise, it's easy because you can use 19 gauge or 22 gauge needle. And in terms of adverse events, it's very low. So I think if you are treating PNET, it's definitely a good option. But of course, if you are treating anything other than PNET, then RFA is another thing you can consider. So. Okay, thanks. Thanks, Anthony. I think we'll now move on to our next speaker. So we're happy to have Dr. Chew Wek, senior consultant from Tan Tock Seng Hospital, to talk about drainage of pseudocysts and wand.
Just click here.
Oh,
Yeah, a very good morning, everyone. I'm Wita here from Tan Seng, and very thankful for the opportunity. I have to thank Prof. Ang and Prof. Andrew Kwek for inviting an opportunity to speak at this talk. So today we'll be talking about optimizing success in wand and pancreatic fluid collection drainage. No disclosures. Just a rough guideline that we'll be talking about pancreatitis and the types of fluid collection, management of necrotizing pancreatitis, especially how has it evolved over the years, timing methods of drainage, some controversies in the stent selection, and just an update on tools for necrosectomy. Yeah. So as you know, acute pancreatitis is one of the most common GI emergencies requiring hospitalization. And even though 80% they actually are quite mild and they will be discharged well and it will resolve, but however 20% actually experience necrotizing pancreatitis, which may require multiple interventions. And the mortality rate for acute pancreatitis, the main difference actually lies in infected pancreatic necrosis. So actually this development is quite crucial. And I think all of us has known that this Atlanta classification where it has kind of standardized all the pancreatitis and fluid collections that we know. And routinely is divided into 4 weeks where necrotizing, will be considered wall-off necrosis, and before that is acute necrotic collection. And how do we assess collection? So sometimes, as you know, a lot of the patients will come in, we will be doing CT scan on admission, but actually the absence or presence of necrosis is best assessed at least 3 days after the presentation. And controlled enhanced CT can identify necrosis and encapsulation, but often they are not so accurate to detect solid or necrotic contents, and also within and outside pancreas, and they also may not be able to look at pancreatic duct so well. So MRI and EUS actually are superior to it for assessment of necrotic material. And also a good fact is that infection of the peripancreatic necrosis often occurs approximately 10 to 14 days from the onset of acute pancreatitis. And obviously, as we mentioned earlier, this will worsen the prognosis. So you can see there was this natural history where they actually noted that when you do see gas and encapsulation inside necrotic collections, is kind of present in both patients with infected and non-infected, but however, obviously it's more common in infected necrosis. And importantly is how do we define whole intervention? I mean, classically, all of us have been taught the 666 rules, but however, nowadays, I think there's a paradigm shift towards these few indications, the around necrosis, and if they are symptomatic, pain, nausea, vomiting, can't tolerate orally. Infected necrosis, such as gas bubbles or imaging, you have aspirate that confirms microorganism, and high clinical suspicion, especially with patients who have ongoing organ failure after acute pancreatitis. So, meta-analysis of 71 studies with 6,000 plus patients do note that infection in pancreatic necrosis increase the risk of death at least twice, and then also increase your risk of organ failure and ICU admission. However, this trial, the famous monitor trial, actually did point out that there is a chance that conservative may work. Because in this trial, actually, a significant portion of patients in the post-post drainage group actually was successfully managed with antibiotics alone, without requiring further interventions like drainage or necrosectomy. And looking back, sometimes we do think of whether can we predict pancreatic necrosis. These are like 2 papers that actually look at some of the identification of early predictors. But you can see that one part is alcoholic etiology, because they do know that alcohol itself does increase the permeability of the intestinal layer. So sometimes they do get increased risk of infection from bacterial translocation. And you can see that sometimes creatinine, albumin, all these are early predictors. And you can see there is a big paradigm shift in the management of necrotic pancreatitis from the olden times where everyone gets surgical necrosectomy, and then it has evolved from surgery to become something minimally invasive, and now it's more evidence care. And especially after the introduction of lumen opposing stent in 2013. So that has kind of revolutionized the whole management of necrotizing pancreatitis. And later on, we'll be touching on the RCT on the timing of necrosectomy, the Destin and Wonder 01 trial that just came out this year. Yeah. And just a very concise comparison of the major guidelines from the most recent ones from AGA. Our Asian group, EUS group, also did have one in 2018 by Prof. Anthony Teoh also. But that time was mainly more focused on shoulder cyst drainage. I think in general, most of the timings are the same. That means we still aim at about 4 weeks, if possible. And then generally, all guidelines all recommend minimally invasive approaches, more of an open necrosectomy. And summary of some of the interventions for necrotizing pancreatitis, you can see from A, B are the more open surgical necrosectomy type. C is a laparoscopic necrosectomy. And we still have our percutaneous drainage for actually the difficult to reach areas, paragolic cutters, yeah. And then obviously nowadays, one of the first line will be endoscopic transluminal necrosectomy. So I think without doubt nowadays, EUS-guided drainage is one of the first line option, and at the same time it provides access for endoscopic necrosectomy if we do plan it later on. And there was these two meta-analysis that shows that basically there's a benefit of endoscopic drainage over percutaneous and surgical drainage. Yeah. And obviously we all know about these 3 famous trials, Penta, Tension, Pointer, by the Dutch Pancreatitis Study Group, that actually shows that conservative first and minimally invasive approach is better. So it's a less is more better approach. And especially in the Pointer trial, they compared immediate versus postponed catheter drainage in patients with infected necrosis. The immediate drainage actually experienced a higher procedure burden with no big difference in outcomes. And this is actually an interesting review by intensive care unit about what should we do nowadays. Yeah, so I think as you can see, one of the main route is still about endoscopic as the first line, and then it's a step-up therapy. And but however, we also have to be mindful when to bring IR or surgery into the plan, especially when it's early phase in the first 2 weeks where the collection is immature, deep paracolic gutter or pelvic extension, and very ill patients not fit for prolonged endoscopy, and sometimes failure of the necrosectomy. Yeah. And I mean, earlier on, timing of intervention was always kept at around 4 weeks in view of encapsulation to happen. But however, I mean, recent trials shows that EUS-guided drainage can be safely performed if the PFC is well encapsulated. A multi-center Dutch study did note that about 43%, that means half of the demarcated collections, will start to develop within the first 3 weeks. So actually not the timing is important, but more on scans, whether do you find encapsulation and liquefaction of the contents that is important. This is just a brief summary of the techniques. I mean, the picture on the left is basically the stepwise insertion of wire-guided double pigtail stents, where you actually puncture, you pass a wire, you dilate the tract, and then you exchange for equipment and exchange for stent again. And you can see on the right, obviously, this is the lumen opposing stent, where it's actually a kind of a one-step procedure, where I mean, there are a few fixed buttons, which I think most people are familiar here. And it's a one-step procedure. It's definitely much faster and seamless compared to the plastic stent insertion. And this, obviously, this brings us to the big questions about the choice of stents, lens versus plastic. And nowadays, I mean, there are actually more data coming out, I think from the Japanese group, Italian group, and actually also from our Asian group, that basically lamps is kind of easy to use because it's less steps and less accessories, and perhaps maybe you don't even need that dedicated team compared to previously, which sometimes not all units in the world may have a dedicated nursing team just for advanced endoscopy. And advantages, fluoroscopy not required. It's a shorter procedure time. Among all the trials, this was the most significant. Basically, you take 15 versus 45 minutes. Even though the inner diameter, this is larger, but actually the outcome so far on the studies has proved similar. And obviously, in a single procedure, the lens is actually a higher cost compared to plastic stent. But so far, by the Axioma study by the Dutch pancreatologist group shows that the total cost is actually comparable. So this gives us some food for thought. So you can see since then, there are actually quite a lot of prospective studies studying lamps and double pigtail stents for endoscopic wound drainage, and yeah. And in general, you can see over on this side, all the costings are not much of a difference. No statistically significant difference in the success, the mortality, the need for necrosectomy, and adverse events. Though lamps was noted to have higher bleeding risk, but it's not significant. And even in the latest CGH guideline, they do recommend that actually for necrotizing pancreatitis, you do decide there's a role for both. That means both lamps and multiple plastic stents, but have to depend on the characteristics of the fluid and the patient. Yeah. And sometimes some size and shapes of collections may be unsuitable for lamps. And basically for fluid cavity, clinical outcome is kind of similar between both, but lamps are easier and faster to insert. And lamp sometimes is preferred in the critically ill patients or large collections with significant solid necrotic debris because we in preparation for necrosectomy. Yeah. And to put or not to put, I think this is always a question that plug all advanced endoscopy, whether do you put a double pigtail stent. There are touted two benefits. One is to reduce risk of infection by food reflux in cavity. And then the other part is that the coaxial double pigtail stent actually prevents the direct contact of mucosal vessels from distant flange of the lamps following collapse of the cavity. But data is still conflicting because I think there was two kind of single-center trials that noted reduced in adverse events. But there was a large multi-center trial that actually reported in the US that lamps actually did not significantly reduce overall adverse events. And And even for the VetNet trial that was in 2023, it just shows that occlusion and occlusion of the lens is lesser. But however, the overall outcome of this is still similar. And actually, that brought us to some interesting questions. One was to actually take note that one of the most important determinant of bleeding in WAN is actually our pseudoaneurysms. And this study by in GIE 2022 actually do note that no matter which stent you use, it did not determine the incidence of the pseudoaneurysms. But bleeding from pseudoaneurysm induced by erosion of lens may occur in the first 2 weeks, prompting individualization or removal interval. So this maybe can actually postulate that lamps actually reduce it faster. So actually we may have to go in earlier to remove the lamps rather than later. And I think a big question is also when do we remove lamps? I think traditionally the 4 weeks interval came from this study by I think it's Shyam's group, I think, yeah, where they actually noted higher risk of delayed bleeding when they remove the lamps at about, I think, 41 days. Yeah. But subsequently, I think quite a lot of studies came out, and as you can see, there was a big meta-analysis of 1,820 patients that showed that actually it's similar for both early and late removal. And removal of lamps within 4 weeks is not warranted. Yeah. But looking through some major guidelines, I think one is the Italian guidelines and the other one, the Chinese guidelines, that basically more than 4 weeks can be acceptable when clinically needed. And some do note that if your lamp size is big, all this, you do take caution. But basically, a practical approach will be to reassess at 3-4 weeks, and then once it's removed, then basically once the cavity is resolved, then you can remove it. And now I want to talk about timing of necrosectomy. So I think this is a big discussion recently between I think of the Street Fighter, a helicopter kick immediately into the storm. And the other one is a step up where you store power, wait for liquefaction, and then you one time, clear it all. Yeah. So I think it first started about 2 years ago, where there's a destined trial by the pancreatic disease, the US group, and they note that it's a multi-center 5 US 1 India RCT trial demonstrated that undergoing immediate then after initial drainage had fewer overall interventions and shorter hospital stay. And then subsequently, the Japanese group actually do the wonderful 01 trial where they actually compare with the step-up method, immediate then after EUS-guided drainage, reduce time to clinical success without increasing adverse events. But however, they do require more necrosectomy procedure. So it's to know that in both trials, there was no difference in adverse events or mortality between the two groups. Then subsequently this year, I think came a new trial again, looking at this again. So first is just published in, I think 1 or 2 months ago, the Danish group. They randomized patients with one, but it's actually quite big. It's 15 cm to either group. And they have to terminate the trial early on because of safety concerns. Because in the step-up group, they found that the patients had kind of have major adverse events, whereas in the immediate group, they didn't note any events. And then you can see the length of stay in hospital for the accelerate group actually was much lower, and this was significant. And then second part is the Iranian group where they actually randomized 50 patients, and then we've infected one containing about 20% to one is to immediate, and then the other one is to versus on demand. And it did show that the immediate necrosectomy group required more and longer necrosectomy lesions and had more occurrence of severe adverse events. But however, I mean, if you do have time to go and read into the studies, the study design, the patient population is very different because the Iranian group, all the collections are much smaller. Yeah. So you sometimes can even argue that if you don't do anything, they may actually just get better. Yeah. So the last part, I'd just like to touch on some necrosectomy tools. First is our old friend, this hydrogen peroxide lavage. Yeah. So as you know, it's antimicrobial, hemostatic, and wound healing characteristics. And by right, you can do chemical microdebridement, and then you can mobilize the necrotic content. And the 3% is usually diluted with normal saline in a ratio of 2:1 to 10:1. I mean, I use 10:1 also because sometimes there's a lot of bubbling, I think. So it's infused either direct or via a nasocystic catheter. So sometimes the theoretical risk is that it can have gas embolization because I think when it meets with catalase, all this, it forms oxygen and water, I think. Yeah, and then when the amount of oxygen is more than the blood solubility, it can have theoretical risk of gas embolization. Second part is excessive bubbling until you can reflux the contents and patient may aspirate. Yeah. Not sure how many of you here do use hydrogen peroxide, but when I last tried, first time when tried, it does have a lot of bubbling, so you do have to be a bit cautious, especially if you are doing the patient not under MAC, monitor anesthesia care. There are some other chemical necrosectomy that people, basically streptokinase. So with that, they show that there is some reduced need for necrosectomy, and sometimes also use for anhydrous ethanol to actually clean up. But however, this is still you will need clinical studies, And I think this was the trial in 2021 where they noted that this H2O, hydrogen peroxide, basically had a higher clinical success and a shorter time to resolution. But however, I mean, the criticism of this study is that the concentration used, the WAN, the necrotic contents, all these are not standardized. And so basically they showed that the clinical success is 91%, and actually it's actually noted to be quite safe. No, I don't think so far that meta-analysis have not any gas embolism, and most adverse events actually is related to the WAN debridement rather than use of hydrogen peroxide. But when this came out, Top Baron is actually quite quite against it because he feels that it is a problematic solution rather than a solution to the problem. Because he feels that the study designs are heterogeneous, the indication, the methods, and the concentration and volumes are not standardized. And I think the other part that we always know is the proton pump inhibitor, like we should hold off because gastric acid can actually help us facilitate liquefaction. This started with this multi-center retrospective study of 270 patients where they noted that non-PPI use basically is associated with fewer necrosectomy sessions, 4.6 versus 3.2. And a large German study that multi-center retrospective cohort that just published last year showed that if you are off PPI, your LAMS occlusion, all this is lower. And then PPI use is actually also associated with higher rates of necrosectomy. So no increase in other complications such as bleeding events. So basically, they do recommend to hold off proton pump inhibitors. But however, looking at the trial is that they didn't really note that whether the patient, as in they didn't, in the trial itself, it didn't really take note of the medication the patient is on. As you know, locally, there's a lot of patients that are on aspirin or novel anticoagulants. So I think this part maybe have to be investigated. And coming to the end, it's just some devices for them. I think traditionally there's always a lack of dedicated devices. We are using snare, forceps, net, dormier, whatever we can use to pull out the gunk. And two meta-analysis noted that our median number of dance sessions are about 4. So I think nowadays there are a few kind of dedicated device. First one is the over-the-scope grasper by Ovesco, the excavator. And basically it's a plastic tube where it's an extra large transparent cap with distal grasper. Then you can actually move into the stand and then remove the debris out. But however, you have to take note that this is not teeth. That means it's actually quite smooth. So sometimes the harder ones you may not be able to pluck out. And basically, a multi-center study showed that the 97% technical success, mean duration is about 59 minutes. But basically, there's no moderate or severe complication, but actually half the time they have to remove the scope to clean inside. So basically, this may be still one on the downside. And then obviously it's easier in a 20 mm lens. And then next is this motorized device, endorotor, where it's a automated endoscopic system designed to perform tissue resection and suction simultaneously. So you can see it's sucking the gunk and then removing. And then it showed that basically technical success 100%. But however, I think one of the main issues is that definitely the dance sessions, all these are less. But the issue was that this 5.1 mm endorotor will require a therapeutic OGD with 6 mm working channel, which is, I think, very hard to get for most centers. So there is also a higher than reported adverse events, and 11% of the DEN is terminated due to completion of the functional life of the catheter. So I think it's still something interesting, but we still have to work out. Other than devices called the WAN, basically using water to debride the necrotic tissue while preserving viable tissue. The other one is Necrolab by Italian group where they have basket container, they have stainless steel, ultra steel fluid all embedded in one. But basically, all these are still under trial. Yeah. And then lastly, just something new that came out, basically a Purostat. So for when you encounter bleeding, this is something that you can consider. Because sometimes acute or delayed bleeding is a very common thing in post-EUS-guided lamps, and there is some technical challenge in hemostasis, especially you get fragile necrotic tissue. There's a partial constraint there, and sometimes you can't visualize. Yeah. So basically, Purostat was applied 100% to the patients, and basically successful hemostasis 96%. So advantages are is inert material, easy to use, and possibly there's some healing properties. And some limitation of studies basically show that it's retrospective and there's no control group for this. So in summary, basically, just a few things to note. Endoscopic drainage should be governed by degree of encapsulation rather than onset. Conservative approach can be an option in some infected pancreatic necrosis. And obviously, transmural endoscopic mural drainage is the first line. So choice or stents should be individualized. And necrosectomy timing still to be determined, but I guess it's reasonable to do it earlier if conditions are suitable. Stopping PPI, if possible, may help, and we have to compare the newer mechanical devices and chemical necrolytic agents with traditional methods. And yeah, I guess necrolytic is basically multidisciplinary, depends on expertise, and you have to personalize according to a clinical condition and progress. So with that, thank you so much. Yeah.
Any questions?
Right, any questions?
Or anyone in the audience know? If you want to know.
Or can I ask, do you all routinely use hydrogen peroxide or no?
But yeah,
Other profs did, yeah?
in many countries, hydrogen peroxide is forbidden to use. Creation of oxygen radicals and also risk of embolism. But it definitely works. But in many countries, this is forbidden.
I see.
So that's not allowed. But indeed, it's a good surgical practice, which functions. Yes, if I may have just some minor comment about the PPIs and withdrawal of PPIs or not indicating PPIs, it definitely works. However, it needs to be strictly individualized. If you have a patient with a severe present pancreatitis, that's a usual part of the protocol that is on PPI. So in certain cases, yeah, it helps, but it can also have a patient off PPI can cause another complication. So I would be very careful, with those data. But it works. Yeah, that's true. That increased acidity helps faster.
Yeah.
Necrolysis.
Any more questions? If not, thanks, Arita.
Yeah, thank you.
So we have Anthony again to talk to us about EUS-guided gallbladder drainage.
Right. So I'm going to be talking about gallbladder drainage. I think you know that I started my research career in publishing a lot in this area. So in terms of endoscopic methods of gallbladder drainage, as we know, EUS is not the only way. In the past, quite a few papers describe the transfibulary method involving the insertion of nasal gallbladder drains or a plastic stent, which is basically a ELCP procedure. You cannulate the CBD and then try to selectively cannulate the cystic tub and insert a plastic stent into the gallbladder. Of course, this technique is technically demanding and the success rate is a bit lower. So with the advent of lamps, which is really designed for gallbladder drainage, gallbladder drainage has been taken over mainly with the use of the transmural drainage. If you look at the published studies on comparing EUS-GBD versus ETB-GBD, basically technical and clinical success is better with the EUS method. There's less recurrent cholecystitis and procedural adverse events is less. So in general, EUS-GBD is preferred. Of course, for gallbladder drainage, the concern is it is a non-adherent organ, is mobile. So if you puncture, if the gallbladder goes away, then there's a risk of leak and also risk of stem deployment. So you need to be careful. In terms of management of acute cholecystitis, as a surgeon, I still have to say that Coli is still the standard of care, and only in those with very high risk candidates or in patients that are very old, they do not want to have surgery. According to our drug studies, EUS-GBD should be preferred over percutaneous drainage for these patients. From our drag 1 study, we showed many benefits as compared to percutaneous GBD. So risk of recurrent acute cholecystitis, re-interventions, 1 year adverse events rate were all significantly less with EUS gallbladder drainage. And in terms of longer term outcomes, 18 studies, 700 patients. Technical success rate was extremely high. Risk of cholecystitis recurrence was very low, 4.2%. Remission rate in 1 year was 19%. Re-intervention was 6%. For repeat endoscopy was extremely low, and stent patency was 418 days. So really very nice outcome. And according to ESG guideline, according to Rashti, EUS-GBD should be favored over PD-GBD in view of these evidence. And also according to the AEG guideline, indications include acute cholecystitis at high risk for cholecystectomy, long-term PTC, malignant obstruction failure, EUS-PD, and contraindication is again green or perforation gallbladder drainage. Right now, I think Shannon is doing this study comparing EUS-GBD with antibiotic first. I think in some hospitals they would give a trial antibiotics first and see if the patient, if they don't respond to antibiotics, then provide drainage. And this study looks at the early use of EUS-GBD, whether this is beneficial. And in terms of interim results, in the EUS-GBD arm actually was much better. There were much less re-interventions. Hospital stay was shorter, so on, but continued recruitment is ongoing. In terms of technique, as a surgeon, we are always aware not all gallbladders are the same. There are some easier ones and more difficult ones. If you think you are treating a difficult gallbladder, try to drain with the conventional method. So if it's a small gallbladder, if there's previous percutaneous drainage, then you use the traditional technique, needle guide wire tract dilation and stent insertion. But if you have very distended, inflamed gallbladder, nice position, then you can just go for a direct puncture. For the conventional approach, we are using the same devices, so needle, 90-gauge needle, guide wire, dilatation with cystotome, balloon, or if you have lamps, then direct puncture. I mean, puncture with the corneal enhanced lamps. So this was a recent case, 92-year-old lady, 1 week history of right upper quadrant pain. Just pain, no fever. White cell count normal, CRP normal, liver function normal. CT shows distended gallbladder. Radiologist just told me there was no stranding or cystic fluid. So this is the films. I'll take you through how I think about this case. So, oops, sorry, this is the other way around. Let me. Oops, okay. Okay, should be like this. Okay, this is the gallbladder right there. This seems to be the standard. And then this is the neck of the gallbladder. Duodenum, I think here. And then you see the stomach and duodenum. So, Rusty, you're the surgeon. Do you think this is cholecystitis?
Might be. There is some content in the gallbladder though.
Yeah.
It's
Difficult, huh?
yeah, difficult.
Because all the inflammatory markers are normal. She has no fever, just pain. Any worry about doing US gallbladder drainage? Anything that you might anticipate difficulty? You think this is a stone here? Yeah. This is a big stone. I don't know. I was worrying a bit about a big stone at the neck. Because there's a big blackish, I don't know, something like that. Okay, so in this case, in terms of planning, several things were going through my mind. Is it acute cholecystitis? If it is, then in theory it's easier for drainage, but if it's not, it's just what we call a biliary colic or very obstructive gallbladder, but not inflamed, then there might be some issues. Where to drain? I was worried about a stone at the neck of the gallbladder, very close to the duodenum. So if there's a big stone there, there might be difficulty on inserting the stent. The gallbladder was a bit more to the other side, to the percutaneous side, more to this side. So there's only one window of drainage, which is just here. So I can't access the other area. So not 100% sure it's possible. Stones that might be at the neck, obstructing the view. So these are things that were in my mind, but we still prime the patient. There's a maybe 70 to 80% chance of success, but if it doesn't work, then we can think of other ways to do it. Okay, so this is on insertion endoscope. You can see this is the gallbladder. As expected, it's full of stones here. But it seems the gallbladder seems to be like this. So the stones are floating right here. So maybe there's still some space for drainage. So I inserted a needle here, aspirated. And then inserted the guide wire. There's some contrast, seeing multiple stones. Then here I'm using the hot spaxer stent. So I use the conventional method because I anticipated there might be some difficulty. Right here I'm pushing. You can see this is the hot spaxer, the corollary thing. So here, usually it goes in very quickly. So I'm burning and then it should go in. But if you can feel it, I'm actually pushing everything away. So it's not going in. So keep trying. So sometimes if the gallbladder wall is very thickened or there's some chronic inflammation, it becomes fibrotic, what we call a fibrotic. So the puncture may be difficult. So again, push. And then again, pushing everything away. So in this situation, make sure you don't lose your position, because once you lose your position, then there's difficulty. And then suddenly a giveaway, I feel a giveaway, and actually I'll make sure I see the biliary system going inside. No, actually, this is this one. I push again, and then finally Here, there's a giveaway, and then the delivery system went inside. So a feeling of relief. And then once the delivery system is inside, then I carefully pull back, and then you see the stent opening, and then we pull back the stent and then open the proximal flange and push it out from the channel. So right here you can see this is the stent. With this image, I'm still a little bit concerned because the flange is not open very well. You can see some folding. And if that happens during manipulation, sometimes the stent will be pushed out. But with some more movement, the stent will open a bit better. So because of all the stones inside the gallbladder and elderly patient planned for long-term standing, I put an additional big towel into the gallbladder. So this is what it looks like. I have inside. So plan for permanent stenting. Okay, so in terms of drainage, where should we drain? We always drain through the duodenum, and in this paper, they showed that the symptomatic lamp-related AEs are mainly related to the gastric location. So if you put it through the stomach, try to there's a risk of food substance going inside, and also risk of buried stent syndrome. But if you put it through the stomach, try to use a smaller size stent, maybe 1 centimeter. Long-term setting versus cholecystostomy. We used to remove the stones and then remove the stent, but they found that this method was actually worse. So long-term stenting had better outcomes, less recurrent biliary effects, less recurrent cholecystitis, and all that. So long-term stenting is definitely the way to go for these elderly patients. And you can see recurrent biliary events is less. Cost-effective analysis, I think if you use axials, the cost is mainly the most costly is the stent itself. If you use axis, maybe it's cheaper. So although EUS-GBD is associated with low cost of intervention, low cost of planned admission, still a bit expensive because of the stent. There are some patients who have long-term PD-GBD. So they have a blocked cystic duct requiring long-term PD-GBD. We can convert these to internal drainage, but you need to be careful. These procedures are more difficult. The gallbladder is less distended. You need to check if the PDC is inside you. Sometimes the cystic duct becomes patent again. It's difficult to defend the gallbladder. There are some reports using the use of fluid or gel through the PDC to make your gallbladder better, distended better. Definitely a good option. So patient on long-term percutaneous drainage, again a big stone here, gallbladder not very well distended, small gallbladder. Again, puncture with a needle first. You can see the cystic duct was already opening. Well, the gallbladder was not very well distended. Again, needle guide wire, and then very small target. Here, this is a stone right next to the stent. So again, handle with care in this situation. And once the proximal distal flange is opened, then the remaining part of the procedure is easier. Surgery candidates, can they receive endoscopic drainage first? There are several scenarios as a temporary drainage method before lab chole. You can do either ET-GBD, which may be better accepted by surgeons, or you can also do EUS-GBD, which we are now also accepting. As a drainage procedure, maybe still quite controversial because the risk of recurrent stone is still high. From Siam's group, they are very against this in patients with potential surgery because they found in their series some patients with LAMS precluded a minimal invasive approach. Therefore, EUS-GBD should be reserved for patient of never surgery patients that are broadly classified as high-risk surgery candidates. Of course, with our experience, both Rusty and I, we found that actually it's not the case. So actually, you can still do lab chole with all these patients, and his series submitted to DDW a few years ago, 81 patients had lab chole. For these patients, we now adopt a remove the lamps first protocol. So all patients should have their lamps removed and allow the fistula to close. And once the fistula is closed, we don't need to repair. 86% do not require repair of fistula, and conversion only in 2 patients. The median operative time was very short, 44 minutes. So basically the same as regular cholecystectomy. So cholecystectomy after EUS-GBD is safe. And in this meta-analysis, comparing the outcomes of interval cholecystectomy after EUS gallbladder drainage, they found that the lab chole was still successful in 76% of the patient, open cholecystectomy 14%. AES quite acceptable, 13%. So again, similar to a regular procedure. This was one of those procedures that we do it with a robot. Again, the fistula tract cannot be seen, just a very small amount of fibrosis around this area. So no need any repair. So essential points on cholecystectomy. The lamp should be removed surgically to allow for fistula closure. If you have a longer period of time, of course, better. But in Rusty's experience, maybe just around a week should be okay. And that doesn't necessarily make lab chole more difficult. New indications. There are studies looking at prophylactic gallbladder drainage for biliary obstruction. They show that with gallbladder drainage, you can reduce the cholecystitis rate and also the requirement of hospital admission. Of course, again, some people think it's too much. And then, of course, for me, I think we just comparison between risk and reward. So if you are very familiar with the procedure, of course, low complication rate, then of course you can consider doing them. And another indication nowadays is for biliary obstruction. If the patient has a patent cystic duct, in patients with where both bowel drainage and gallbladder drainage is possible, then actually results seem to be similar. So technical success, clinical success, adverse events rates seem to be comparable, and perhaps you can also do this for some patients. So EUS-GBD for acute cholecystitis is an advantageous technique of EUS-GBD is becoming standardized, and attention to details is important. So thank you.
So sorry, I'm a GI surgeon. I think I have 2 questions. One, for those that you put the stent permanently, did it create any problems in the long term? Do they occluded or they lost?
So in general, for these patients that are all elderly, so some multiple comorbidities, limited life expectancy. So most of the time it doesn't create any problems. If they are small stones, a lot of times the stones will pass out themselves. If they have larger stones, then there might be a sort of like ball and socket kind of obstruction. So we would insert a plastic stent, additional plastic stent to just keep the stent open. I did have one patient we came in with GI bleeding. So the patient was on NOAC, so the oral anticoagulant. So in those patients, maybe there's a risk of bleeding. But for that patient, it's just bleeding from the stent-induced ulcer. So for that patient, we remove the stent and then sort of heal it itself. Otherwise, I don't see much obstruction.
And then when you perform this procedure, you put patient supine or patient rise up.
So you can put them in sort of like an ERCP position, which is prone, or you can do it on lateral, similar to OGD position. If you do it prone, then with X-ray, if you need the X-ray, you can see it better. If you do it on lateral, sometimes you may not see it so well. But in many situations, X-ray is actually not required, so you can even do it in the ICU setting.
And I'm quite amazed that you, by the time you do the leg fully, the stent removal is within 4 days. Means that you remove the stent, you 4 days close.
Yes.
And the stent you use is 20 mm or standard.
In that series, majority of vast majority of or all of them, actually, sorry, 10 millimeters. 10 millimeters just to have it cool it down. The important factor also for the safety of cholecystectomy is also to have cool it down cholecystitis, so that the interval is at least 12 weeks since EUS-GB was introduced and cholecystectomy is performed. Initially, we started with this procedure where it was removed at the same time as cholecystectomy, just to be worried about the identification. But then later, kind of we figured out that within 4 days this is closed. There is no fibrosis. This types of anstenosis. So it's very nice position serosa to serosa. So there is no foreign body like surgical suture or anything else. So it nicely by position serosa basically kind of separates between gallbladder and duodenum. So it's kind of like a surprising outcome because we would expect that it would make surgery more difficult. But for the same reason, we are using this procedure even for those patients who need to go later on for major pancreatic resection because it doesn't affect anyhow surgical intervention. So 4 days it's really enough. Most of the time you don't need to even close the fistula. If there is some consent, there is some remaining tract, there is not complete separation. Just sutures with needle or stapler,
Okay, I think maybe we go forward to the next topic, which is EUS-guided HGS and CDS. I think it's pretty heavy going.
All right, so optimizing CDS and HGS. Okay, so in terms of US biliary drainage, before going through that, again, I would like to stress the importance. ERCP is still the gold standard. So it's a basic procedure for all pancreatic endoscopists, so we still like doing ERCP a lot. But of course, EUS-PD is becoming more and more mature. In terms of bowel drainage, we have transmural techniques like Momivu and integrate stenting. And then, of course, we have choledostomy and hepatogastrostomy, which are both transmural kind of stenting. So current indications, mainly for failed ERCP, either failed cannulation or inaccessible papilla. We are seeing expanded indication like the primary EUS-PD, EUS biliary drainage for pre-op biliary drainage before Whipple's. So potential advantages include avoids the risk of placing stent across the tumor, maybe pronounced stent patency, reduced procedural time, no risk of pancreatitis. So EUS-PD versus ERCP still very controversial. For me, it's complementary. Both, if you know both techniques, then your success rate will be much higher. Your stent patency is better, no risk of adverse events. Tools is always the same. Needles, guide wire, tract dilatation. cystotomy, non-cautery dilators, stent, lamps, tubular lamp stents, single step devices. In terms of tract dilatation, we are more familiar with coronary dilatation, cystotomy. But then there are new devices. So guide wire, my go-to guide wire is always 025, and then I would use the angle tip basic light. Dilators, we are more accustomed to the cystotomy, but in Japan they have switched to non-coronary dilators. The red dilator, is the red dilator available here? No, okay. Taurus, they will be launching in Asia, so starting in Hong Kong, so maybe next year in Malaysia. In Singapore, you should have it. The Taurus is kind of like a screw type of dilator. It's very secure and very good for even a very tough pancreatic tissue. In terms of stents, there is probably tubular duckbill shaped stent lamps, tubular type stents for HGS, and also plastic stent for HGS. So in CDS, you can use both lamps and tubular stent. For HGS, you are using mainly tubular or plastic stent. So in terms of single step device, it definitely makes all these procedures much easier because you can direct puncture into the bile duct and perform CDS. And it allows performance of procedure quickly. It's a reduced difficulty. So if you are starting the procedure, makes definitely easier and shortens the learning curve. Deployment systems, be aware for lamps, you have the endoscopist control system, and then for tubular stents, you are requiring a system control. If it's endoscopist control, allows precise control by the endoscopist. You don't need an experienced assistant and useful for small targets like the bile duct, but of course it's more expensive. You need to have training and practice. So for CDS and HGS, okay. So for CDS, you can do it either with single step hot lamps, 6 or 8 millimeters. Main issue is risk of Sumner syndrome, so food getting into the gallbladder because of a very short stent. Or you can use a tubular stent, but this is multi-step, you need tract dilatation. Some say it's associated with better patency. HGS, it can be single step or multi-step. Most are still doing with multi-steps. And again, nowadays you have a short option of doing inserting a SAMS, which is usually permanent, or you can insert a IT stent, where in Japan, I think almost by default they would insert a plastic stent nowadays. So with lamps, it's very easy. This is the first procedure by one of the trainees. That is the standard puncture with a needle. So since the first procedure, you do it with a needle. In general, bile duct, it's a narrow target. So unless it's very distended or you're very confident, I would suggest you start with a needle first and then inject contrast, and then guide wire goes in, and then exchange the needle out. And this is the cautery enhanced tip. We burn our way through. And then be aware the stent is backward opening, so we need to insert deeply, and then we open the distal flange. You see it's very narrow. And then once it's open in the bile duct, you pull back and then deploy the proximal flange in the channel. and then push the stand out from the channel. Like that. And then he is inside the loop. So with the lamps in the bile duct, if you insert it perpendicularly, the opposite side may impinge on the opening, and also fluid can go inside to the bile duct relatively easily. So you can insert a plastic stent through the lamps, or when you insert the lamps, try to have it inserted at an angle. That's what I try to do, so that the opposite side doesn't impinge on the wall, and the bowel flow is more downward. So this is one way. For HGS, usually it's a multi-step procedure. You insert about a needle, followed by guide wire insertion, and then track dilation with a cystotome, and then stent insertion. So this is a hot geo ball, needle, wire, and if you think the direction is smooth, so once you have straightened out the wire, then you can just insert directly with hot geo ball. And here try to push the stent down. Sometimes this angle is very acute. So the stent went down, and then you open the stent at the and then again the proximal part of the stent open inside the channel and then push it up progressively. So with the hot geo ball, technical clinical success is very good from patients. Every procedure time 16 minutes. No patient with severe adverse events. And then IT stent. It is a special stent, so there are no holes in between the two sides. It's a very long stent. In terms of the stent itself, it is very close to the delivery system. So technical success is very good for HGS. You can leave it in the patient for long term. It's removable, so you can leave it for drainage or just for access as well. So which is better? So this paper from Vinay, quite recent, they compare a transpapillary method, antegrade stenting, versus a CDS or HGS. So 120 patients. There were no difference in technical and clinical success, no difference in AE. But unexpectedly, they found the transpapillary method, antegrade, was actually better. Time to recurrent obstruction is less. So the transmural method from his study was actually associated with lower patency. In terms of systematic review by Tawfik, 5 randomized trials, 515 patients, EUS-PD versus ERCP. I think this is for primary USPD, so malignant distributor obstruction. Found that USPD was associated with lower intervention rate than ERCP, US with LAMPS, and it's higher clinical success. But the studies are quite heterogeneous. So these first three studies are older ones. They were doing US CDS HGS with a tubular stent, and then another one with a CDS with a tubular stent, the one by Cheyenne, small study with a tubular stent. And then there are two studies from myself and from Yanni, doing CDS with LAMPS versus ERCP. So very heterogeneous, I think. So for the ones that Yanni and I did, we didn't find any difference in terms of CDS and ERCP in terms of stent patency. This is similar for Yanni's study. So we concluded that both procedures could be options for primary biliary drainage in unresectable malignant distal biliary obstruction. And you can also consider primary CDS when you think the ERCP is potentially difficult. We also published the risk of adverse events in a study. So we classified the stent misdeployments into several types. Type 1 is the misdeployment of distal flange. Type 2 is proximal flange. Type 3 is double puncture of the bile duct, and type 4 is double mucosal puncture. And basically, even with all these stent misdeployment, I think most of the time it's just mild to moderate AEs and can be salvaged endoscopically. And I think in terms of risk of stent misdeployment, most importantly is the bile duct diameter. So if you have a small bile duct diameter, you need to be careful because the stent distal flange may deploy outside of the bile duct. So always puncture with a needle and guide wire. So I think in conclusion, there are many advances in EUS-PD, and with expanded indication of primary EUS-PD, careful choice between both procedures is best, and different EUS-PD techniques are required depending on the patient's characteristics. So thank you. Any questions from anyone? Not any comments.
No, I don't have any particular comments. I think that was a presentation. So
now we move on to we continue the topic of biliary drainage, and now Prof. Rastislav Kunda from National University Hospital will talk about H.
The AGMI.
Okay, sure. You joined the Zoom already?
Yes.
Okay, then you can use it. So you can share your screen through your laptop. So turn on your camera.
Okay, is it on?
Not yet.
Would you want camera or me?
Yes.
It's
It's
okay.
okay?
Let's start.
It's okay. Yeah, nobody wants to see me. Okay. So again, my apologies for this technical glitch. I will be talking a little. First of all, I appreciate being here. So I'm doing it from here.
No, you're doing it from here.
Okay. Thank you very much for having me, and I appreciate invitation to speak on a couple of topics. I mean, I will be talking about US directed transgastric ERCP. I have a bunch with different for surgical anatomy, and one of those, especially in Western population, is edge procedure, or as it evolved to this name, edge. So it's post-bariatric intervention following endoscopic sleeve gastroplasty. Bariatric gastric bypass. I apologize. Consequence of bariatric Roux-en-Y gastric bypass is that it comes with some shifts in metabolism, particularly metabolism of cholesterol, and thus can be associated also for this as one of the reasons with series of complications, including cholelithiasis, acute cholangitis, or cholecystitis, and acute pancreatitis. There are multiple highly efficient modalities which are also safe and proven over a very long time how we can address these pathologies. Mostly, however, despite high frequency of bariatric surgery in many parts of the world, this still requires these treatments are centralized in specialized centers who have a more multidisciplinary approach and also have expertise in these procedures. So obviously this doesn't fully correspond with the growing need because we have growing population of patients following bariatric interventions. So we also need to tackle these pathologies. So local experience and expertise should always be considered when you are basically commencing this type of treatment. There are multiple ways how we can gain biliary access. For many years, gold standard has been laparoscopic assisted ERCP, either transgastric, mostly transgastric, or eventually also possible as a transjejunal access. Obviously, there is still a place, those diminishing for enteroscopy assisted ERCP, double balloon, single balloon, overtube assisted, but also previously with spiral or motorized enteroscopy. Percutaneous approach with PTBD obviously cannot be also forgotten. And then we have what just Professor Teoh was showing, EUS-guided hepatic gastrostomy. We can use it in similar manner for transgastric and transhepatic antegrade approach to target pathologies in a bile ducts or liver. EUS-guided gastrogastrostomy, or so-called edge, they have been over the time promiscuously changed with procedure, but let's call it edge for the simplicity and also to avoid confusion, is the last and probably most broadly developing procedure in recent 7-8 years. Laparoscopic assisted ERCP has very nice safety profile, which is comparable to conventional ERCP. Though overall adverse events are slightly higher because you need to also at laparoscopy related adverse events, so then it's a little bit higher overall adverse events. The difference for endoscopists is basically that if you don't have experience, that position of the endoscope is slightly less stable, and it's not so comfortable as you can see with standard ERCP, where you have these 3 points of frictions in cardia, in your pylorus, and eventually in front of the papilla. So it's a little bit more position which is rather unstable, but still for a skill endoscopist, that's perfectly feasible procedure. There are very moderate risk of clinical success. It works very well. Limitations sometimes come with it. Now I'm talking about enteroscopy assisted ERCP, I apologize. There are some limitations when you come at the end to the papilla that you're getting tangential view. It can be unstable in terms of the working platform. We don't have forward-viewing endoscopes with elevators, with the exception of few not very frequently used endoscopes. There is suboptimal accessory performance because the channel is usually very long, and then you are losing all the way your tangential and also your longitudinal force while manipulating these devices, which are already limited by the size of working channel and tortuosity of the scope trajectory. So indeed, there is also a limited portfolio of these procedures, and we need to also take into account potential risk of postoperative adhesions following previous surgery, and the risk of perforation by the scope introduction. Enteroscopy assisted ERCP can be, as I mentioned, be done in various manners with the support of overtube, single double balloon, and usually it's reported in terms of success rate somewhere between 38 to 100%, but typically what we see in one of the centers is somewhere 60 to 70%. So it's highly dependable on the expertise of the particular center. If we compare in balloon assisted ERCP and laparoscopic assisted ERCP, and plus we clearly see that most of these procedures in terms of papilla identification, cannulation, and complication rates can be favoring laparoscopy assisted approach. There are also guide wire assisted techniques which allowing us kind of simplifies or guide us to approach papilla and the change anatomy when we are going all the way through Roux-en-Y anatomy. And again, we can also approach these things antegrade by the means of interventional EUS through the lateral lobe and deal with it that way. In standard gastric bypass, bariatric gastric bypass, so we are connecting gastric pouch with a disconnected distal remnant of the stomach. We are typically doing it in the fashion of gastrostomy, but it's completely feasible and sometimes also necessary to do it of gastrostomy when you are going just below the surgical gastroduodenostomy. For the reconnection, we use different types of stents, but now we are obviously talking about lumen metal stents who are allowing us to create this access anastomosis. On the right side, you can see different names of the procedure from gastrostomy, internal edge, and so on, gate, which is gastric access for temporary endoscopy. But currently, mostly in literature, you can find term edge. But again, if you go to the old searches, so there have been all these references when we were using this procedure before we agreed to call it edge. This allows us to address pathologies like CVD stones. We can perform also some other pancreatobiliary interventions. We can perform EUS with FNA or FNBs. Tissue procurement, we can also do some luminal interventions in gastric remnant or duodenum, which is otherwise inaccessible. Thus, this edge shows us or serves us, as clear access anastomosis. There are some considerations, always obviously look at your imaging. What is the pathology? If there are stones, how many they are, what is their size, what is the dilation of the duct. Obviously, you want to also evaluate how it looks with the disconnected stomach. Antibiotic prophylaxis, it's a good standard of practice. It doesn't typically require any specific diet before the procedure. Patients have just the gastric pouch, so no need to have any other reservations concerning this. At procedural phase, that's about the lump selection and potentially lumps fixation. Especially if we are doing the procedure in the same session. So it means you have patient with presented with acute cholangitis or acute cholecystitis, when you need to perform ERCP, and then it doesn't require, but it's recommended to fixate the stent to reduce the risk of dislodgement of the stent. Otherwise, we do it as a two-step procedure when it's good practice to have an interval between insertion of gastroenterostomy and ERCP at least 7 days. I typically do it usually after 7 days. Anastomosis, if it's well performed, it's have a nice and it's complete already after 3 days. If there is a free fluid or any other content in the abdomen, so it may take longer time, but I'm not hesitating to go there after 7 days. In post-procedural phase, PPIs, diet, and fistula closure are also things to be considered. For the terms of size, if we are talking about Hodaxios, I'm typically choosing either 15 or 20 millimeter stent. I tend to stay with a 10 millimeter in terms of length, rarely in 15 millimeter. Very important, and probably the most important thing while you're performing this procedure is to understand what is so-called $10 sign. When this seashell basically has been named by Todd Barron, and we are using it as a major landmark in our EUS, where we can identify a disconnected portion of the stomach, gastric remnant, and then puncture it and perform anastomosis from the gastric pouch or jejunum just below the pouch. So it has this typical appearance like a star shaped or $10 cent. And then depending, how big is the volume, how big is the distension of the distal portion, the remnant of the stomach, you either inject, or typically you inject through the nightingale needle some saline to distend it and provide better target, better ultrasound coupling, and then introduce either over the wire or without wire 15 or 20 millimeter lumina posimeter stent. Procedure is possible to be done also with patients who have done not just gastric bypass, but also combination of gastric bypass with sleeve gastroplasty, surgical sleeve gastroplasty. There is a less space, but it's completely feasible. It's also good practice when you are doing it, do it obviously under fluoroscopy, and place the anastomosis as high as possible in the remnant, not to go too close or too low towards pylorus or on the curvature, because then you can much easier manipulate the scope and scope in a much stable position. If you do it in the same session, it's good practice to dilate the stent to its maximum diameter and fit it. But as I said, typically it's non-urgent setting, non-vital indication. You can wait 7 days and then safely perform it without stent fixation. Stent fixation does not completely eliminate the risk of stent dislodgement. So that's also part of the considerations. So again, $10 sign. In this case, you see there is not much space between gastric folds, so you puncture it, and there is done distension by the saline. Following the puncture, injection of saline with some amount of contrast. you distend to a reasonable volume, gastric remnant, and then deploy proximal flange and distal flange, and basically the anastomosis is created. Then it can be dilated, and then you can use it as an entry point for your ERCP. What is very important to understand, and what is the beauty of this procedure, that we are creating mimicking a normal positioning of ERCP scope, like in native non-surgical anatomy. So it's very stable. It almost looks like your axials become like your cardia. So it stabilizes in that position. And you can perform in very nice same mimicking situation ERCP. This is another example of another case where you can remove stent, and you can see how the fistula looks like. In old days, we used to close all the fistulas. It's typically like a longer fistulas channel. We used to actively close them. Now we are even controlling patients afterwards, several weeks. Now we are calling on the patients who have unexpected, or in other words, gain of weight. Vast majority of these fistulas are closing spontaneously very fast. So and we don't even do routine endoscopy. The access, obviously, it's a little bit more difficult if we are using, for example, EUS scope. We would like to take, for example, pancreas biopsies, or using EUS scopes for drainage of the gallbladder. You need to be careful how to introduce. You need to know how to maneuver through the stent. Again, stent removed, you can appreciate a fistula and gastric lumen. And again, left for spontaneous closure. If you need to close, it's relatively easy to close it, obviously with overstitch. But I think that the simplest method would be used these days, X-Tech by approximation, or use over the scope clip. And again, you can also appreciate here that the scope is passed through the axial stent, and really typical position of the duodenoscope, as we see with any other ERCP, and you have then solitary stone. If we are looking in comparison of H versus laparoscopic assisted ERCP, there is similar technical success in adverse events in both groups of patients. ERCP, there is a shorter procedure time and hospital stay attributed to H, and also offer minimal invasiveness, and it's a very effective option. And there is no observed any significant weight gain in these patients. We also did some comparison of H to enteroscopy, which we published back in 2018 in a small group of patients, where there have been statistically significant benefit for technical success, procedural time, and length of hospital stay after the procedure, favoring H over enteroscopy assisted ERCP. There are multiple protocols how to go, what to do. This differs from institution to institution. This is from Brigham and Women's, Boston. I introduced in a couple of my institutions basically algorithm which is based on anatomical findings and presence of gallbladder. If there is presence of gallbladder, obviously it's more reasonable to go with laparoscopic cholecystectomy altogether with laparoscopic assisted ERCP. If a patient has been cholecystectomized before or in between, or doing the bariatric procedure, then it depends on the size and number of stones. Where there is a multiple or larger stones, then we are more prone to perform H rather than transhepatic antegrade approach by hepatic gastrostomy. We also publish in our European Interventional EUS-guided comment on this, and make also with one of the conclusions and recommendations, though based on low quality evidence as a weak recommendation, is that it should be offered to patients who has Roux-en-Y gastric bypass following multidisciplinary decision making. if there is a good expertise in the centers. There are a number of studies published on EDGE. Most of them, though, are retrospective. There are only 2 prospective studies. Up to today, there are a few meta-analyses done, all of them recently. In summary, as for the evidence, AEG and EUS-G guidelines support EDGE, because also AEG has guidelines on this, as a first-line therapy for pancreatic disorders in by gastric bypass patients in centers where there is expertise presence. There is already verified and emphasized superior technical and clinical success rate over 95%, which is higher in comparison to endoscopy-assisted ERCP. EDGE over laparoscopic-assisted ERCP demonstrates shorter procedure duration, easy reaccess, and reduced length of hospital stay, and also more favorable cost effectiveness. Overall adverse events for EDGE range somewhere between 14 to 18%. They may go from some ulcers, weight regain, bleeding, and perforations. But also there are some adverse events related to LEMS itself. Efficacy and safety is satisfactory. There is no need also by studies to have any kind of like a routine follow-up of fistulas and the healing. Adverse events have been proven not to be significantly different between EDGE, laparoscopic assisted ERCP, and endoscopic assisted ERCP. We still may need, and probably they are already ongoing, if I'm not mistaken, randomized control trial addressing also this, because there is definitely enough patients. There are a couple of studies I would like to probably point out, also very recently published by Over Devest, maybe Antonini, focused particularly on the EDGE. And there are also some review articles where we more worked with Vanella and Somanjavillano published look at some procedures and surgically altered anatomy, because that's the part of the entire spectrum of procedure we are talking about. So it's definitely novel approach, but it allows us to address this surgically altered anatomy safely and effectively. Thank you very much.
Here we go.
Thanks, Prof, for the excellent talk. So I just want to check with you, is there any role to put in plastic stents to maintain patency or this, or for all these lamps, or for the procedure, or?
For EDGE procedure, no. There is no. We have big luminal structures, and if we consider it for dislodgement, I do not believe it would significantly affect. This is relatively safe procedure, you know. Despite that the stomach is disconnected, it's relatively non-mobile. You know, it's and you can safely perform it. You know, stomach wall is thick. So if you do puncture, and if you are not happy, you can repuncture different place, and you will not get any leak from that. But I do not see any role of plastic stent in this at all.
Okay, thank you.
Thanks, I have a question. In terms of how soon after putting in the lamps would you do the EUS-PD? Do you have to wait or can you do it?
If it's non-urgent setting, okay, so I don't have a patient with acute cholangitis. In my word, acute cholangitis is something which needs to be treated within 24 hours. So it means that I do it everything in the same session. The procedure is done the same fashion, like standard procedure. I just fix the stent with an overscope clip. Okay, it doesn't eliminate dislodge, because you can, as you push too much, you can dislodge a remnant, and it will simply slip out of the flange of the stent. But if it's non-urgent setting, so I wait 7 days. Okay, you have people who wait 3 weeks, 4 weeks, 7 days. It's safe if there is not any impaired healing or ascites. After 7 days, you can safely do it. In non-acute settings, I rather wait. But 7 days, it's sufficient, absolutely.
Now we are using lens. Actually, like for example, for Afton limb syndrome, for candy cane, even for those patients who have severe malnutrition post Roux-en-Y gastric bypass, we want to create a permanent fistula. So for these benign cases, right, is there any way we can, like for example, if we keep the indwelling time longer, can we make it into a permanent fistula even after we remove the stent?
Yeah, that's an excellent question. I don't believe so. It depends on which pathologies. If we are connecting, if we are creating enteric anastomosis, yes, that would be possible. But if candy cane or afferent loop syndrome, it would close. It's a different type of anastomosis. That fistula tract will close. So in afferent loop, most of them are in malignant settings. So I don't see any harm keep this for the patient. In candy cane, it's a little bit different, but usually patients can stay over the long time. There is that benefit to keep patient over the long time, and you don't need to exchange that stent frequently, if ever. Again, it depends on the particle indication, life expectancy, and so on. I had a series of patients where I did esophageal diverticuli, non-operable patients with a severely altered anatomy who cannot eat at all. So we did transdiaphragmatic esophagogastrostomy, basically creating double barrel connection, through cardia and through this neo-anastomosis. But typically they were old. But lumen aposimetal stent doesn't allow you to have permanent anastomosis from the stomach because the thickness of the wall. Even enteric anastomosis, it's a little bit non-consistent, but they can remain patent because there is not much fibrosis. So it's really like a serosa to serosa, but that tract which we create by the fistula that you can see that there is no fibrosis. So it basically heals very fast. Within 3 to 7 days, it's closed.
So you just leave the stent there as long as you can.
Yes.
Until the patient becomes symptomatic again.
Yes.
Then
I have patients where stent needed to be changed maybe after 3-4 years. I have patients 10 years with a stent and nothing has been changed. But I think those are questions which maybe comes with time. We've been talking about, I don't know, gallbladder, and I don't like to see gallbladder stents longer than 12 months, but that's my personal opinion. Because I believe if you have patients who have longer life expectancy, that it's not really optimal pH for a gallbladder.
And then for those stents, they leave it for 3-4 years. When you remove it, it was okay. Doesn't have ingrowth issue and things.
No, typically not. There is not much reactivity if it's between these luminal structures.
Maybe can I just ask a few questions, then we move on to the next talk. From family perspective, you use the 15 mm stent lens, and even for delayed cases, you put a vessel clip. Okay. And
can you repeat your question?
Okay, so use the diameter wise is 15 mm lens.
Typically, I use 15 or 20.
Okay.
Yeah, 20 we now not have available. It's temporarily on the market. We're hoping to have it, but even before, but many prefer 20 because it's much easier to pass with the endoscope.
Okay. Yeah, and you always, even for the case 1 week later, you put a,
No, I don't fix delay cases.
okay, fine.
I fix only I like to do crazy stuff, but I don't like to overcomplicate it. So
Sure, okay.
I like that the simplicity, the beauty is in the simplicity. So I like just to keep the stand, not fixation.
Sure, because by then there'll be a mature track.
Yes,
It
yes.
will not cause a free perforation.
It will be strong enough
Yeah.
that when you push, when you manipulate scope, so you don't pull the stomach. You know, you still need to be careful.
Sure, okay.
It's not like a strong anastomosis, but it's strong enough to not
Yeah.
to separate those.
Sure. I saw your management algorithm, right? For those who impact gallbladder, they go for cholecystectomy. Your option was chole plus lab assisted ERCP, right? What happened to the lab CPP exploration and zone extraction?
That's because you didn't carefully read my slide. Because it was my algorithm.
Yeah.
So in that slide, I don't want to share it again. That was my slide from my paper and a protocol from my previous couple of institutions, but introduced in Aarhus, Denmark, where the role of laparoscopic assisted exploration of the CBD and enteroscopy assisted ERCP was diminishing. And laparoscopy assisted exploration of CBD, it's strongly based on the institution preference and skills. You know, it's an expertise. But when you have a center of excellence in endoscopy and interventional endoscopy, interventional EUS, so the role of laparoscopy exploration is diminishing. And again, it's about looking for the options. You know, if patient, you know, what is the size, but typically in my institutions, we've got higher expertise in this, and I'm an HPB surgeon. We had a higher expertise, even myself, with endoscopy rather than exploration. You know, exploration, it's more technically difficult, demanding, I would say. I'm not saying that impossible, but I would rely more for the centers who really roll, you know, routinely perioperative cholangiography and routinely do this, not just do it on one case a year. You know, that's where outcomes come with the routine and expertise.
Yeah. Okay, thank you.
Thank you. Thank you.
I think we come to our final lecture before we have a discussion. I'd like to welcome Dr. Teh Jun Liang, who's a senior consultant surgeon from Ng Hospital to talk about EUS-guided GJ creation.
Okay, thanks, Prof. Wang. So I'm Jun Liang. I thank you again, Prof. Wang, for the opportunity to present during this AEG meeting. I think it's very hard for me to come after Anthony as well as Rusty, who trained me extensively for ERCP as well as EUS. But I'll try my best to talk about my experience with EUS-GE, which is a very topic close to heart, and see whether I can share some peers with you with regards to my experience over the last 2-3 years. Okay, so well, patients with advanced upper GI malignancies often present at some point of time with GOO, and we usually manage this traditionally with surgical GE or duodenal stenting. But we also know that surgical gastroenterostomy is, even though it's a rather straightforward procedure, can be done laparoscopically and is associated with high technical success rate, but it is also still invasive, even though it's usually done laparoscopic and it's associated with longer hospitalization stay. There is a trend towards longer term survival, but probably because there's a bias where usually patients with better prognosis undergo surgical GJ. However, surgical GJ again is not without challenges. Patients are often frail, they are malnourished. Sometimes tumors can be quite in a difficult position, and the lab GJ can also be challenging. post-op, of course, you have to worry about anastomotic leakage, delayed gastric emptying, and so on. So there comes the opportunity where EUS-guided gastroenterostomy is now fairly commonplace and not so novel anymore. I think it's been in clinical practice for the last 10, 11 years. And it's a method of creating anastomosis by insertion of a lumen opposing stand, we have heard several times today, between the stomach and duodenum or the stomach and jejunum. So similar to a surgical GJ, it allows extra anastomotic gastric drainage with minimal risk of post-operative surgical GJ complications such as a leak. So just to cut to the chase, this is how we usually do it. You see this. Okay, so this is how we do a surgical GJ. This is one of my older videos when I'm in fellowship with Teoh. Basically, we identify the tumor first, and then we pass a body catheter and a wire beyond the level of obstruction. And once that is done, we can delineate the small bowel. Probably the more challenging step is really getting the wire past and trying to get a tube, usually either a nasal-biliary drain or a very small French feeding tube across the tumor. But sometimes if you use a feeding tube, sometimes it can be quite difficult because it can be floppy. So now I think nowadays we use more of a nasal-biliary drain to do this step, and it's slightly easier because it's a more stiff factor. So once that's done, you can switch to a EUS echo endoscope, and then you can try to identify a suitable loop of bowel. Usually this is just beyond the level of ligament of Trex, and you want to look for area with adequate runway. You can see that while trying to look for additional good landing zone for the stand, we are also pressing on the foot pedal to insufflate the small bowel with fluid. So once we find a good runway, we can usually quite easily perform the lens deployment, usually with a 15 or 20 millimeter axial stand using hot cautery. Yeah, so now you can see that the distal flange is already deployed, and then you can very quickly switch over to the endoscopic view where you can see the blue fluid coming out. And why there's blue fluid is usually when we insufflate the small bowel, it's usually filled with contrast saline as well as a methylene blue or indigo carmine, and then you can confirm that your position of the stand is in the correct loop of bowel. So this is how we do it. There's several methods that's been described. If you look in the literature, how EUS-GE is performed, and it ranges from the direct puncture method where they will just deploy a stand across a small bowel, or to rendezvous methods, as well as at some point of time, people were also doing some balloon catheter assisted method where they will target, they will put a CRE balloon beyond the tumor, they will inflate the balloon, and then they will target the balloon as where they wanted to land the stand. But I think nowadays the methods that we usually rely on are either the nasal-biliary assisted technique, or like what we mentioned. We can also use a feeding tube in place of nasal-biliary drain, like what we mentioned before, or the EPAS method, which was in place about 5-6 years ago, but it's probably more common in certain centers around the world and not widely available worldwide. I think the last few years I've seen a bumper crop of level 1 data suggesting the superiority, or at least the non-inferiority of EUS-GE compared to duodenal stents as well as surgical bypass. So I think Professor Teoh has published quite a famous the Gu paper, which is comparing EUS-GE versus duodenal stenting. And what it shows us the primary outcome being 6 months reintervention rate. Actually, reintervention rate within 6 months was much lower in the EUS-GE group compared to the duodenal stent group, with better gastric outlet obstruction scores at 1 month in the EUS-GE group. Then last year there were two randomized controlled trials comparing EUS-GE versus surgical GJ. In the Goose trial that was published by Shams and Wang Jiang's group, they actually randomized. This was actually a superiority trial comparing EUS-GE versus surgical GJ. But in this group, most of patients actually receive open GJ. So the outcome was that of composite measure of a gastric outlet of score of 0 or 1 at discharge, which is a poor score. The need for re-intervention or supplemental nutrition for 6 months adverse event rate. And what it actually showed was that if you look at this, 74 patients were randomly assigned to EUS-GE in this study, with half of them receiving EUS-GE and about the other half receiving a surgical GJ. And what we can see that the primary endpoint was actually achieved much higher in the surgery groups, showing that the surgery group actually had poor outcomes. So the primary endpoint occurred in about 8% of patients who received EUS-GE versus almost 40% in the surgical GJ group. And patients who in the surgery group actually had more patients in the surgery group had liquid diet only at discharge compared to most patients in the EUS-GE group being able to tolerate some form of solid diet at discharge. The time to start the solid diet was also much shorter in the EUS-GE group compared to the surgery group. Again, the length of hospital stay was shorter in the EUS-GE group. And so it does suggest that cost-wise as well as patient outcome-wise, it seems that EUS-GE is superior to the surgery group. This was again confirmed at a trial that was published later in the year, in the Dutch trial, where patients were assigned randomly either to EUS-GE versus surgical versus lab surgical GJ. And the primary outcome this time was a bit more simpler, no composite outcomes, but rather they just measured the time to resumption of solid oral intake or GOO score of more than 2. So in this study, interestingly, they also showed that it was actually performed over a very short period of time, over 2 years, where they rapidly accumulated almost about 100 patients with GOO. So endoscopic GE actually had a shorter time to solid diet control compared to those with surgical GE. And also the persistent or recurrent obstruction for which re-intervention was needed was fairly similar. But clinical success was somewhat higher in the EUS-GE group. The median length of hospital stay again was shorter in the EUS-GE group. So it's actually quite interesting. And also in this study, which is not demonstrated in this table, they actually demonstrated that the patients in the EUS-GE group had a better survival in the first 50 days. So suggesting that these patients with very advanced malignancies may actually benefit from a less invasive procedure to overcome the surgical to overcome the complications so that they can move on with their chemotherapy. Yeah. So I mean that's all the data that we're going to show in terms of EUS-GE being more superior to stenting or surgical GE, but we should look probably at how we can optimize outcomes in surgical GE, which is what the crux of this lecture is. So I think there are certain things to consider, and one would be pre-procedural preparation, and the other one will be intra-procedural techniques that will help you better optimize your outcomes in surgical in endoscopic GE. So what this paper actually shows is that so how do you choose patients that are best candidates for EUS-GJ, right? So I think the surgical dogma has been that if you expect your patient to survive for about a year, then you should do a surgical GJ. But if you don't expect them to survive, just for a few months, then you do the stenting. That was the dogma that we were taught when we were being trained during surgery. But I think now with EUS-GE being sort of an intermediate procedure, we can actually offer this to certain patients that are more frail, but probably we also need to consider that they still have a decent expected life expectancy before we offer this procedure. And what this paper show actually is that patients with ECOG more than 2, as well as patients with ascites tend to do poorly. and they tend to demise within 3 months. And this is again shown in our own series of about 40 patients undergoing EUS-GE, where patients with low BMI as well as patients with poor ECOG score have a very high risk of 90-day mortality even after EUS-GE. So that's patient selection. Does stent size matter? I mean, in this case, unfortunately, it probably does, and you should really know your lumen opposing stents. So again, this is a very old paper published by Professor Teoh suggesting studying the lumen opposing force between the Axios, Nagi, and Spexer stents. And it shows that the Axios and Spexers had higher lumen opposing force compared to the Nagi stents. And again, this finding was replicated about 6-7 years later by another Japanese group, suggesting that the anchoring force of the axial stent was higher compared to the Spexers and the other lumen opposing stents. So I think in EUS-GE, where your small bowel can sometimes be mobile and there's a lot of peristalsis, you do want lamps that's able to stay in place and withstand the force of peristalsis. But I think overall it's been quite safe, and we haven't had a case where there is a spontaneous dislodgement of a GJ. I think it's quite rare and rather unheard of. So comparing 20mm and 15mm stent, I think Moen's group in 2022 suggested that patients undergoing EUS-GE 15mm versus 20mm stent had similar clinical and technical success rates. The 20mm patients were able to tolerate more complete and softer diet, and similar rate of adverse event and stent maldeployment was observed. So I think in view of the better quality of life that patients with 20mm patients who receive the 20mm stent have, it's probably preferable to have to implant 20mm stents for EUS-GJ. This is quite a nice paper that actually studied the clinical and demographic factors on outcomes. So over a long period of time, this group did about 140 EUS-GE procedures with high technical success and clinical success rate. But they did demonstrate that patients with gastric obstruction had less clinical success. Patients with peritonial carcinomatosis had less technical success as well. And interestingly, patients who underwent NGT decompression were associated with lower adverse outcomes. I think in this paper, they didn't really specify why these patients had lower adverse outcomes, but it's probably due to the risk of aspiration pneumonitis if the stomach is adequately decompressed before the procedure. Because if you remember, a lot of times, even during the procedure, we are pumping quite a lot of fluid. So especially if the patients are not intubated and so on, then they may be at risk of aspiration pneumonitis. Okay, so I think a few technical factors that we have to consider. One is that's not been really mentioned so far, is that the runway of the axial stent, because the axios is actually a backward deploying stent, so you do have to puncture the delivery system as you go in further, quite a far way in before we withdraw the sheath for the stent to be deployed. And for the 15mm and the 20mm stents, you do need a runway of about 4 centimeters. And this is often, most of the time you can achieve a good runway in the EUS-GE, but sometimes you may not be able to have a nice long runway and you may just have a circular target. And that's when you may have to rely on certain other deployment techniques. So usually to deploy the axial stent, there's a 4-step technique. The first step is when you activate the hot cautery and you puncture through the target. So generally, it's advisable to advance the step 1 as far as you can, but sometimes in a small target, you may not be able to push it all the way in, because if you push all the way in, then the end of the delivery system pushes against the back wall, and that might dislodge the stent or move the target away. So I think in those cases, it's still you will have to either use the incremental technique or you use the push technique. I think I managed to rip this video off somebody's speaker, but this is how they do the push technique. Shift this away. So you don't see very much happening on the screen, but he's deploying the axios in a different way. So the step 1 is actually unlocked, and he's actually deploying step 2 while pushing the step 1 in. And if you look on the screen, then you can see that the wheels is actually not spring back like before, but it's actually is kept in a fixed position, and then the stuff flange is being deployed. So this method is helpful in small targets. The other way is the incremental deployment method, which is fairly similar. So basically, you puncture as far as you can. You activate step 2, but while activating step 2, you don't deploy step 2 all the way, but instead, you deploy a little bit, and then you unlock step 1 and you push it in a little bit. You push the flange, the delivery system a bit more before completing the step 2. So I think there are certain very fine nuances that will help you reduce the risk of mal-deployment. Also, this is less applicable for EUS-GJ because the 20mm sheath, the 20mm stents and 50mm stents are quite difficult to resheath. But actually, there's a way to resheath the axial stent, and usually there's a safety latch to prevent where after you deploy step 2, you actually feel a click, and that's a safety latch that keeps the distal flange in place. But this can actually be removed in the smaller flange stents so that you can actually try to resheath. Sometimes I think this may be a little bit helpful in CDS, even though it can be quite a stressful situation once you have a mal-deployment. So if you see after they remove the safety latch, or sometimes you can just use a finger to push in the safety latch, then you can see on EUS view that you can actually resheath the distal flange of the stent. So there are some little trick you kind of know. So I guess no optimization or better success factors can be completed without showing some mal-deployments. So this is one of my first, I think my second case after coming back from Hong Kong, and then you can see it went in quite nicely, but then this was one of those horror stories where the 20mm stent didn't open. So you can see that the edge of the stent is actually here. So usually you look for a black marker. The radiolucent part is where the stent usually is. And as we try to activate step 2, the stent doesn't open. So I think at that point of time, I think I didn't really understand the stent so much. So we had difficulty, and we wanted to remove the stent, and there was a lot of manipulation and things like that. Eventually, we lost the access. But I think the trick, is probably you have to know that sometimes if this happens, then you can either jiggle the stent, so unlock step 1 and try to push in and out the stent a little bit and see whether it opens up. If that fails, then sometimes you can bypass step 3 and just push out the stent a little bit more with the proximal deployment to see whether the stent opens. But having said that, I think recently Axios has been there's quite a lot of sizes apart from the 10 and 15 have been recalled due to certain deploying problems. So I think it's best that we use this time to understand how the stent actually works. This is another video where I would like to demonstrate that. So a few mistakes. Number one, I left the Doppler on while puncturing. I think this is so once you're sure that you're going to puncture, it's probably best off it because you really want to see the stent go in very nicely while stepping on the cautery pedal. And sometimes having these artifacts from the Doppler while you step on the cautery is really you can't really gauge whether the stent is going in well. But in any case, the stent actually went to a small bowel. The other mistake that you can realize is that the small bowel is actually quite far away, and once I puncture, I can tell that I don't really have enough runway. So once you activate step 2, and that's when I'm really trouble. So you can see that the stent is opening up close to the wall of the small bowel, and that's where you get trapped and you will not be able to be adequately. I tried to push in the stent, but I think with the stent already half open, it was very hard to get the flange in. But in any case, So some experts, so when you can see, once you open the stent, you realize that you are actually outside the bowel lumen, because this is probably where the bowel lumen is, and you're in no man's land here in the peritoneum. So I think some experts will tell you that once this happen, there are certain ways you can. There are certain get arounds that you can do. One of them is notes, but it's not so simple. But at this point of time, actually, I already decided to bring the patient to surgery. So I decided to just explore a little bit and see what it was like to do notes. So I dilated the stent, try to put a scope in, and it's actually extremely difficult because you just see bowel all over the place, and you won't be able to really see where the stent initially went in. So I think notes is probably not for the faint-hearted, and you really need to be very, very skilled to do it. And perhaps it's not really a very good fallback procedure for most of us. But in any case, so you have to understand the different type of maldeployment, like what Professor Teoh mentioned for CDS. There are four main types of maldeployment, and each of them are solved and can be get around with different methods. The first one is where you have the stent in the stomach, and there's no hole in the jejunum. This can be quite easily solved. You can remove the stent, close the gastric hole, and then you can decide whether you are still in good enough shape to reattempt EUS-GE in the same setting. If not, you can always come back another day. The second, the type 2s are a little bit tricky. So the type 2s, you have already punctured through the small bowel, but then you have mal-deployed the stent, and the stent is not in the small bowel. So again, in these cases, I think the surgical dogma is that because you already have a hole in the small bowel, you have to go to surgery. But I think with more recent experience, you can actually tell from this table that some of these patients actually can be salvaged without surgery. What you can do is that you can remove the stent and reattempt EUS-GE in the same setting, but you have puncture fairly close to the site of the enterostomy. And most of the time with antibiotics, careful observation, a lot of patients actually do not need surgery. So the type 3s are where you have a stent in the small bowel site. Most of the time you have to either utilize nodes to create GE, or you have to go to surgery. The type 4s are when you have inadvertent colonic stent deployments. And usually in these cases, we realize on table, we just abort the procedure. You can come back, remove the stent in a couple of weeks while having an alternative bleeding mechanism for these patients during this period of time. I think the last few slides will be to mention upcoming tools that we can help us. So I think the EPUB balloon was helpful when a lot of these trials were being performed, and thereby you see that the rate of mal-deployments are probably much lower than you see in the real world. But one of these devices that have come out from the Canadian group is from Dr. Chen, who has it was called the chest double balloon before, but I think Boston has since bought this device. And what it does is that it's actually very helpful because it's a double balloon occluder. You can actually you see, so this is what it looks like. There's a double balloon occluder and a hub that can be detachable. So you can actually do with an OGD or a therapeutic scope. You can insert the double balloon occluder to where the target bowel is, and then after that you can exchange it and reattach the hub. So again, OGD, you put the double balloon occluder in. You can see that these are the markings of the balloon. Then after that you can exchange it, and then you can reattach the hub. Then after that you can reinflate the balloon. You can inflate the balloon and inflate fluid in between the loop of bowel between, and then you have a very nice loop of bowel that is fairly fixed in two positions for you to do a EUS-GJ. So that this takes away the risk of bowel moving away when you do your puncture. Okay. So I think to summarize, I think pre-procedural, you really need to select your patients, decompress the stomach if possible. Think about sedation, whether you're going to do this with just sedation alone or with the help of anesthetist. You can have wanted sedation or GA I think if you are starting out, this is probably better to do these patients under GA so that things are more controlled. Someone is monitoring the airway for you. You don't have to worry about over sedation, or you don't have to worry about aspiration. Intra-procedural, you really need to have a good understanding of the axial stand or whatever lamps that you are trying to use to understand the runway, know what to do for the different scenarios where you might deploy. The freehand technique is really what we do in EUS-GB nowadays, because if you put a wire, if you try to puncture over the wire, a lot of times the wire has been shown to push away the small bowel. And I think in the near future, we have anteroclysis catheters to help us with bowel fixation. And in the last 1 year, actually, there's this expert consensus for best practices in EUS-GE. I think this will be a lot more comprehensive than the lecture, but I think the important points we mentioned, and this again is divided into pre-procedural and technical considerations. So you can have a look. So thank you very much.
Thanks a lot. So I think we now move on to Prof. Kunda again to talk about EUS-guided PD drainage.
Okay, thank you very much again. So I will try to talk about a little bit on optimizing success in EUS-guided pancreatic duct drainage, actually, so indications and some technical considerations when to do and when to do. Historically, this has been quite a while ago since the first pancreatic EUS-guided interventions has been done. Eric Francois, Marc Giovannini, and Jacques Devier combined Marseille and Brussels group from Europe did first pancreatic gastrostomy. And first rendezvous procedure is also described the same year, also by the different French group of Marc Deprez, but also from Marseille. Nevertheless, the first EUS-guided puncture for the diagnostic purposes reported already in 1995. So it's really 31 years ago almost. We can address different types of anatomies, and we can both address distal and proximal portion of the stomach, depending what we want to do. On this diagram, it's not visualized, but you can also do puncture transduodenally, not just from the stomach, though in the vast majority of cases, we would deal with so-called transgastric pancreatic duct drainage or access. As I mentioned before, we've been working several years ago on technical review and practical guidelines for interventional EUS in Europe, and two of those major recommendations, which were both strong with a low quality of evidence, were dealing with EUS-guided pancreatic duct drainage. With that should be only considered in cases of symptomatic patients with an obstructed PD, when retrograde endoscopic intervention fails or it's not feasible for anatomical or technical reasons. And also other recommendation that EUS techniques, rendezvous EUS techniques are recommended rather than transmural pancreatic duct drainage in patients with favorable anatomy, because there is a lower rate of adverse events in these cases. So rather perform rendezvous than transmural drainage. There are obviously some considerations about when we do these procedures, and part of it is also majority of these patients have chronic pancreatitis, and in all this is our medical therapy, it's our surgical therapy, endoscopic treatment. So there are a number of things to consider. I will not go to all the details for the sake of time, but we need to consider and have patient properly mapped if there is a risk of malignancy. What is the pathology? Where is it diffuse? Is it located? Is it more parenchymal or ductal disease? But nowadays in 2026, we usually see all these patients with a very precise imaging, a very precise mapping of the pathology, so we can anticipate what we should do and how we should do it surgically. Mostly we are talking about proximal distal resections, but the story is rather more complicated, and we have just 12 basic procedures in terms of how we surgically treat chronic pancreatitis, and all of these can be very well justified how you do that, and they have even more variations at a certain point of career, that they're like when using 25 different pancreatic resections, and there is like a major distinction between them. Nevertheless, you have only a limited number of centers performing all these procedures. In many countries, in big European countries, there is only a handful of centers, or 1 center, 2 centers per country. The problem is even more pronounced because that we're not talking about only morphological changes responsible for pain in chronic pancreatitis, but also it's all the brain-gut connection, which makes it multiple levels, which we need to affect and kind of provide relief for our patients. Usually in the past, a step-up approach was preferred, where we started with conservative treatment, lifestyle management, dietary and pain advice, and pain medication. If patients still have persistent symptoms, particularly pain, despite these measures, so subsequent interventional endoscopy or surgery are recommended. Nevertheless, recent, trials and studies, and particularly what was outlined in this so-called ESCAPE randomized control trial, was that early surgery has much better outcomes in comparison to endoscopy first, if you act in this patient fast enough. And also some systematic review with a meta-analysis also pointing out towards early surgery. So where is actually the place for EUS-guided pancreatic drainage? Major indications, I will speak with them a little bit more in details, could be NPD dilation caused by strictures and stones, symptomatic. Inaccessible pancreatic vaginal anastomosis, particularly with some strictures, and again, symptomatic patients. Difficulty in accessing NPD by ERCP, where we have still native anatomy, but we are not able to access NPD. And a very good indication is also complete or incomplete disconnected duct syndrome. There are some contraindications, as an inability to visualize NPD on EUS. Multifocality of NPD strictures is, in my understanding or my practice, more relative contraindication. I still wouldn't exclude these patients. Obviously, interposed vessels are limiting what we are doing. Long distance can affect outcomes and success. In old days, 30 years ago or 20 plus years ago, there were guidelines suggesting any intervention under EUS shouldn't be in longer distance than 15 millimeter. It kind of like it disappeared from the literature, but it was kind of like a common practice, and obviously general contraindications. There is very nice review article. It's an expert review article, which I would like to refer, because it's a very nice summary of good practice, and probably this summarizes the best. And in 99%, I absolutely agree with the conclusions. So in cases of failed and non-feasible pancreatic endoscopy or ERP, EUS-guided pancreatic duct drainage can provide alternative to surgical intervention. It's used typically as a second-line approach where ERP fails, or is not feasible due to surgically altered anatomy. If you have proper indication and patient selection and anatomical mapping by imaging, which we are using eventually in all those cases, so we can start with this procedure. It's written in the paper that minimum requirement is 4 millimeter, and that's one of the points where I disagree, because you can do the procedure also in non-dilated and less than 1 millimeter large pancreatic duct. For example, in the cases where you have post-operative leak from pancreatic or jejunostomy, or even late, and if you have non-dilated pancreatic duct, it's feasible and it's doable to do it also non-dilated duct. Obviously, you need to adjust with the size of the needle, size of the guide wires, and technique requires a little bit different finesse, but it's completely feasible. EUS-guided rendezvous procedure is preferred either with transpapillary drainage, or so-called ring drainage, or as I call it, bridging drainage, where you have one end of the stent in the stomach, the other portion of the stent, the other end of the stent is in the duodenum, and basically drains it across the whole pancreatic anatomy. The choice of accessories depends on preference. In this case, unlike with hepatic gastrostomy, which Anthony was talking earlier, we do hepatic gastrostomies typically without use of cautery, or we can comfortably do it without cautery. In pancreatic duct drainage, electrocautery is very often the only option, because these glands are usually very fibrotic. You don't really want to fail. You would like to have a good access. So it's important to have it at least available if you are not able, and using some like a Torrance device or some dilator, which would allow you to easily pass through the soft gland. But in this case, I would strongly advise to have available small French size of cystotome to provide this coaxial cautery and coaxial dilation of the axis. Most technical clinical success are very close to 90%. It's a technical changing procedure. It's valid for centers who have like a good expertise and a good volume of the patients. If you are skilled enough, you can expand indications and deal with different strictures in pancreatic jejunostomy, pancreas divisum. Typically, what I see are disconnected pancreatic duct syndrome patients. And also, I do quite frequently antegrade pancreaticoscopy following enough enlargement of this fistula tract from the stomach to the pancreatic duct. There are missing any prospective or randomized controlled trials, and there is certainly also not very easy to organize them in this group of patients, especially randomizations, but there are not much even prospective data available. So again, chronic pancreatitis with symptomatic obstructive PD, ruptured PD, post-traumatic PD ruptures, disconnected duct syndromes, pancreatic fistula. All these needs to be considered for the indication, and also very good indication are otherwise patients with normal post-surgical anatomy, post-surgical altered anatomy. So typically from the stomach, you visualize under Doppler guidance your MPD, preferably dilated, as was written in article, 4 millimeter, but it technically doesn't matter if you have skills. You insert guide wire, you are attempting to pass the guide wire antegrade through the papilla, if impossible, leave it in the duct and attempt only transmural drainage. But again, the preference is to do rendezvous or bridging drainage, which also traversing papilla, not just staying in the duct. So those are two options you can do. So here we have EUS following identification of dilated NPD, antegrade injection of the contrast, showing that contrast is not passing because there is a big stone. You can maybe appreciate it over the. So we identify basically anatomy of the NPD, guide wire is passed, and I use frequently 6 mm fully covered stents, especially in those cases where I need to do intraductal treatment. I do not go with the bigger diameters. That's enough. And then following this, you know, like in this case, you can pass, it's a spyglass cholangioscope. Occasionally when I need something bigger, so I use 8 or 10 mm, but it's very rare when I need high resolution endoscopy and do something else in the duct. But in this case, you can very, very successfully perform procedure antegradely, where you often, because of anatomical location, fail to approach and negotiate the stone in retrograde fashion. So again, multiple reasons to do it. There are some of the data published showing complexity of the procedure, but also variable utilities or utensils used for perform this. Typically, it's a combination of electrocautery, also partially balloon dilation. In old days, also using needle knife or needle papillotom. But I think that it's very mandatory to have good accessories and not attempt to do this if you don't have it available readily. And obviously, it would be also a good thing to have navigation needle. You know, in this case, very often you come more in perpendicular shape towards the pancreatic duct. Window of opportunity might be rather limited, and kind of navigating or rotating tip of the needle, special EUS navigating device would be very helpful. We have seen many of those, but all of them are currently not commercially available, but shows very promising outcome even when we use them as a prototypes. Yeah, all of these retrospective studies were showing, you know, nice technical success rate over 85%, or on average, sorry, on 85%, ranging from 63 to 100%, with a clinical success rate nearly 90%. So I think that's a very good outcome. However, short-term adverse events in endoscopy can go up to 25%. There is definitely things to be considered. And again, procedure can be done comfortably in terms of risk of some complications, but you need to really understand, you know, technical nuances, and it requires skills and some volume of patients. I think this is probably too small, but basically that's again the outline of most important studies published until 2024. What you cannot see is basically that all of them are retrospective, so that we are missing prospective or any of the data. This is one of the algorithms which I completely agree with, how you approaching and who you are indicating for pancreatic duct drainage, depending if you fail or succeed with your ERP, if you have native anatomy, if you perform EUS-guided pancreatic gastrostomy or rendezvous. But I already commented on this, but it's very nice map how to proceed with your patients. We definitely need a little bit more standardization how we are doing this. We need more dedicated tools, both for interventional, for interventional EUS for this particular indications. I already mentioned the navigation, your rotating tip of the EUS needles. Some electrocautery enhanced devices can be more tailored for this procedure. Puncture technique also need to be not every needle is suitable, so you need to understand sharpness of your needle, if you need or don't need to do fistula dilation, depending if you are coming with a metal or plastic stent. Stent shots and stent development technique we already deployment technique we already talked about. And of course, we need to look about what is the long-term outcomes and stent management, how often we need to, and if we need to exchange these stents, how often they can stay in situ without the risk of overgrowth or ingrowth, and so on. And also, what is the risk of other things? The question about design trials is usually very complicated demography, but particularly etiology of pancreatitis. There are huge variety in imaging features. Procedures differs. Patients really rely on the opioid dependency, and there needs to be also a unified, pain descriptors and assessment scales. So it's very difficult to create any randomized, maybe easier with the sham study, but then it's again more about the ethical consideration. So although the outcomes of EUS-PD are favorable, so there is still room for improvement as the rate of adverse events is relatively high. This is likely because there are some technical developments to be done. There is non-standardization, or at least less standardization than we see in other procedures, what we discussed earlier today. We hope to improve outcomes. Really, it's about that range, which I showed you, that it can be much lower, it can be higher in terms of clinical and technical success rate. We need to get more data, and especially from high volume centers, and also develop with collaboration of experts these dedicated devices, both electrocautery in-house, but also navigational puncture needles and so on. So it should be so far performed in those skills, or it's advisable to perform it by people who are experienced or supervised by experienced expert with a high volume expertise. And already I mentioned multiple times that we need better quality of data on this. Thank you.
Thanks, Steve, for your talk. Any questions from the audience? No. Okay. I guess everyone's tired. I think before we break for lunch, there are two things we'll do. One will be a short panel discussion on training and credentialing for interventional EUS procedure. Then we do a group photo taking. Then we have lunch outside. We got some bento boxes for everybody who is here. All right, so maybe I'll just sit around here. Face the audience. Don't translate. I just want to. I think they still continue. They can be better from my side. You see? No. It takes Andrew outside. Is Andrew Kwek outside? Okay. Okay, let's start a second. All right, so Andrew, please come in front. So I'm the moderator, so I get to ask questions. I don't have to answer anything. All right, so I think we've heard a lot of interesting insightful talks and perspectives on how we can optimize success, how we can do the procedure. But I guess for many of us here, we all want to do such procedures, right? So how can we actually start doing these procedures? Because increasingly, I think there's all this scrutiny, all this issue of quality assurance, talking about credentialing, and also maintenance of competency for us to implement a successful therapeutic EUS service. And I'm sure a long time ago when you all first started, I'm sure you all were trained in ERCP in EUS-FNA, right? But probably there wasn't anyone else there to teach you how to do all these procedures, right? But you went on and were the pioneers and you started doing so. how can we actually do it? Because in many places, there may not be access to experts like yourself. There may not be that great case volume. Yeah. So yeah.
Yeah, so of course training is very important. So I think when we all first started, you need to know that when you do the interventional procedure, the skills you can acquire them in other procedures. Like for example, all the puncturing, guide wire technique, exchange of devices, you can learn it from ERCP. So very often we will recommend people to be familiar with ERCP and all these procedures, and then of course EUS-FNA is the basis for all intervention procedure. You have to be very familiar with the anatomy on linear EUS. And then when you do these procedures, they are of various difficulty and also of various risks of complications. So as a start, you start with injection techniques, and then as you progress, you start to place drains. So with PFC, this is usually a big target, and then you have time. It's a very stable position. You can take time to be familiarized yourself with exchange of devices. I think nowadays everyone is using lamps, and when I ask my trainee to go back to the conventional technique, they find it very difficult. They need to exchange so many time and then put so many plastic stand, and then they're very used to the lamps, but it's still an important skill to acquire. So definitely you would need to try to learn the conventional technique of inserting multiple wires, dilatation, multiple wires, multiple stand. And then once you are familiar with PFC, then you would want to do something more than maybe biliary drainage. And with biliary drainage, you have many procedures: rendezvous, CDS, HGS, integrate. And if you ask, I think depending on who you ask, most people would say puncture is easy, but the guide wire manipulation is more difficult. So the CDS is sort of like a straight line, so that is easy. So you just puncture, insert wire, dilate, and insert a stent. And then once you are familiar with CDS, then you can try other stuff like rendezvous, HGS, so on. So I think GE or the PD drainage are the most difficult ones, so you probably try to attempt those later. Gallbladder is similar to a PFC, but the caseload is less. So you have the standard gallbladder, if you have a stable position in duodenum, then it's usually just puncture and deploy. So of course in our minds you want to be master of one technique before you move on. But as JL would tell you, you sort of like see one of these procedures every now and then, so you kind of like try to tackle everyone at the same time. But yeah, you also try to have to know your own limits. So that's my idea.
Yeah, I think it's very well said. Yeah, and definitely in vast majority what we were talking about today, both skills for ERCP and EUS are must. You don't need to be super expert, but you need to have a skills. You need to have a perception how to deal with the wire, different accessories. You need to understand your device, your technique. You need to have ergonomy of your space, because you need to be prepared, not just perform the beautiful procedure, because this is exciting time we are living doing these things, but also to or resolve situations where some things don't go so well, and when you need to deal with difficult situations, and when by definition, when you still keep that something is happening, what we call unplanned procedural event, but it's not turning into adverse event, it's not turning into complications. So you resolve when we are doing these anastomosis, so we are basically creating artificial perforations, and you need to deal with it, that it's coming without any adverse events, and if something bleeds or if there is misdeployment, so instead of having adverse events by definition of our lexicon of beta cotton from GI endoscopy, it still stays an unplanned procedural event, so it has no consequences of patient, and it's rather so stand over the shoulders of all those who did it before you, and learn from their mistakes. So, and we all have done that. So there have been like a lot of cases where you learn and really understand safety of the procedure. Learn not just how to do the procedure, but how to resolve difficult situations anatomically, technically. In some cases, when you withdraw from the procedure, it's okay. But in some cases, when you, for example, start with a puncture and you're already puncturing 19 gauge needle gallbladder, it's mandatory to finish it with the drainage. Otherwise, you need to put patient either to percutaneous drainage or surgery because there will be leak, even if you have a thick walled gallbladder. In some other cases, it doesn't matter, but you need to nuance your practice that you understand what are consequences of different technical steps in your approach. And of course, then how to resolve different adverse events. So it's not only about the procedure, but also about missteps and mishaps we may have. And we see, there is a lot of nice data. We are getting more and more data. It's not mostly retrospective. We have beautiful randomized trials about gastroenterostomy. Still technically on standard. That's why we are already showing that it's even superior to surgery, which we didn't even hope for. But we still need more. We need more understanding and also be critical when you are reviewing some of the papers. There is a lot of papers which can a little bit mislead you. Be more open-minded. Look at the others and look to variety of options how people are performing. See the live demonstrations, but see more of them, not just one.
I think my experience was that I think I was lucky to train in the high-aid body center. I trained in Professor Teoh Center, so then yes, I think that the sexy part about EUS is always the intervention, but you do remain very grounded in terms of your basic principles of your linear EUS technique and be very comfortable with FNA. And this would include, so you really train on things like difficult small gist that is sometimes with the puncture. You need to recognize that things are going on. You need to realize that it's not the usual view. You need to see a lot of these cases. So it really helps with also not just with the technical part, but to have a group of friends or colleagues who are up to date with the literature that you can discuss with. My personal experience was that coming back from Hong Kong to Singapore, I didn't really have somebody to help doctor me very closely. Just before Rusty came, now I have, if I have a difficult case, but coming back, so I did learn the hard way. I think if you are starting out alone in your own institution, you do need to get your surgeons on board. I mean, you've seen the cases. I did have a few mouth appointments along the way, and then you do need to. I mean, it's also part of the learning journey. You need to accept that you will have some mobility. Hopefully, not at too much expense on the patient. So get your surgeons involved. And the other thing you have to know is that even though it's not just about wire manipulation and ERCP skills and things like that, you do have to be a generally good endoscopist. You do need to know how to close perforations if you create one. You need to know how to stop bleeding. So I think certain skills are still essential.
I come from a more like traditional background in terms of I learned EUS from like SEL onwards, radial, then to linear, And I was like trained in Taiwan under Prof. Wang Lai Mun which is high volume center. So coming back to Singapore took a while, I think, because as Prof. Anthony Teoh said before, sometimes you plan for all this step up in terms of the scopes and procedures, but sometimes next day the procedure just comes. So I think firstly is that you must always stay ready and go for a lot of these workshops. So and then get hands-on model. I mean, sometimes it's just purely practicing the steps until it becomes second nature. Because I mean, you never know when the case will come, especially I'm sure in Singapore, you know that the volume is not as high, I think. Then second part is that I think it's always good to look for a mentor. I mean, it can be anywhere, maybe in the AEG group. That's why all these initiatives are set on so that we have each other, we can depend on each other and ask for advice. Then second thing is always make sure you read on the patient or the case the night before. Maybe look through look through the scans yourself, look through the blood tests, everything. And second thing also, I mean, nowadays with social media and all the resources, you look through all the videos to see what people do. And sometimes observing and things like that is actually more important than the actual doing. Yeah. So have to be prepared. Yeah. So yeah, I mean, that's my journey so far. We at diagnostic side, we are starting to do a fair bit, but still in the kind of infancy stage and still learning also. Yeah, so now I pass on to
Something my share. I was said that I mean workshops like this help. Now even running the workshops, we get a lot of hands-on. We get a practice on the instruments. Then before procedures, I like to you can get your hands on a sample device. For example, the hot exhales. You're not so familiar the 1, 2, 3, 4 steps. Just run through it. You can reload the stand and all. Procedures I like to video myself. I mean the procedure, analyze it, what went well, what didn't go well. On the topic of credentialing, Prof. Hung is actually our chair of GI endoscopy credentialing, so maybe he can tell us his thoughts on competency based procedural numbers. You're going now.
I'll slowly find answers. I guess the challenge is how do we deal with it in the real world, right? Because we don't have the case volume, we don't have access to, and yet we need to deliver a service. But at the same time, we must ensure that there's some basic quality safety issue. It doesn't matter if it take a long time, but just make sure you deliver a good stuff. So don't cause harm. And gradually, as you become more proficient, your speed will become faster. So there's always this issue of numbers. How many do we need to train? I was just looking at the EUS-GE guideline or rather position statement because there isn't much proper data. So when there's no proper data, people use position statement as that guideline, right? And therefore I think you are co-author. And I think so this was about training curriculum in ERCP and EUS. So they talk about numbers and all that, which actually correlate with as a surrogate for competency. But I think the thrust is that even increasingly we need to look at actual directly observed competency when a person does the procedure. And because I'm also looking at we have seen all these papers, I like your comments on it. I've seen all these papers about learning curve for EUS-CDS, EUS-HGS, and they talk about 10, 20, 30, 40, 50. Then you don't even see maybe so many cases, you don't even see 10 cases a year. So how are you ever going to gain competency? And I think in the ESG position statement, they talk about maybe, I'm not sure how they come up with this number, but they talk about 25 therapeutic procedure under supervision. But I guess again, how can we have 25 of all these individual procedures? Because I guess ultimately, such as say we insert lamps, right? Does it matter whether you insert lamps in the pseudocyst one or gallbladder or GJ? I guess all these skill sets that are transferable. So maybe you need a finite number of procedures. It doesn't matter what you see because ultimately the case just comes. You don't get to choose in a particular sequence. And if within certain number you are competent, then maybe your supervisor can say you can do this rather than splitting the hair and saying for each individual procedure you need a certain minimum number. Rusty?
Yeah, I obviously respect these positions from different societies about volume base, but I do not agree. There is a simple reason because I believe rather in competency-based training than volume-based training. It's nearly impossible to train everybody who needs to be trained and who wants to be trained. There's not enough volume, not enough spectrum of the patients, and also get to achieve the results and outcome of their training. It's not possible, and I know many institutions who are even providing numbers, but the skills and competency are not the outcome of the training, and simply people are not independent to perform these procedures. So I strongly believe in confidence-based training. We can discuss about, let's say, minimum required number of procedures, but it would be just a ballpark number. What I believe. So I respect some positions, but we also know that real life functions a little bit different. You can do some procedures more or less frequently. So some institutions you do some procedure once a month, some procedures you do 10 per month. So it really depends on and so competency based. It's my and you need to find a formula how to issue it.
Oh yeah, of course, agree. And because the numbers are not so many, so in one institution you can't have everyone doing the training. So you probably have to concentrate the training in maybe 1 or 2 individuals at one particular time. And once they are very more experienced, then you can have more people doing.
Okay, so maybe any comments from the audience? Clement just came back from Mayo Clinic, right? Hopkins, yeah. So you get some hands-on training. May I comment your what you think? That my device.
So yes, I also went to a high volume center. I trained under Professor Mun. So was very lucky to actually have had the chance to do hands-on pretty much for most of my time there. Of course, with a lot of shouting right at the beginning, and as time goes by, less shouting and more. Yeah, and more and you get to do more of the crucial parts and towards the end the whole procedure. So but I think something that two main things come to mind when training for such complex procedures is that the first point is very well alluded to, which is that it's not so much getting to hold the scope and doing the procedures, but sometimes assisting, being the person pushing the wire, or sometimes just being the one watching the procedure. I think there's a lot to be taken away from that. So what we used to do, what me and my co-fellow used to do at Hopkins is that we would take turns, and one of us would be the one doing the procedure with Keshab breathing down on our neck. Then the other one would be the one helping the wire or basically watching the procedure. And I think we actually learn a lot from those two approaches. The second thing that I found very helpful is that sometimes when you do a procedure, you don't need to do every single part. There are some certain parts which are crucial. For instance, for EUS-HGS, sometimes the difficult part would be trying to puncture a 3 mm duct. Other times, the patient is breathing very rapidly, and you need to know how to hold position while you do the dilation and the stent exchange. So sometimes, if your supervisor takes away the scope from you as you are, or your proctor takes away the scope from you as you're doing a very crucial part. sometimes this is for patient safety, but at the same time, you get to learn a lot just by doing the other parts as well. That's something that we found very useful. So in essence, you don't just learn by doing the whole procedure, but sometimes the individual parts which are vital.
Yeah, thank you. I think what everyone has said is very, very interesting and relevant. I just have a comment about two things, and perhaps following that, the panel or anybody in the room can give their views. I think the challenge with therapeutic EUS is, of course, the learning curve is quite steep, what we can say, especially starting off. And secondly, is the availability of cases. And I'm wondering, going forward, one solution is more innovations in terms of the equipments, cutting down the steps, because I think in a lot of it, when there's multiple exchanges and prolonged procedure time, that's when things can go wrong. So perhaps should we look into ways in terms of innovating the equipments and I think making innovative stuff more accessible, like for example the E-Pass balloon or the other balloon. Perhaps then we can bring down the learning curve and make things more safer. The other thing is, of course, nowadays we hear a lot about simulator-based learning, simulator-based mastery. I think in the luminal GI training, it's coming. I think it's coming more useful. I'm wondering whether that's another aspect for therapeutic EUS, whether we need to perhaps partner bright minds from engineering fields and things like that to develop suitable simulators to kind of bring down the learning curve. Or is there, I have no experience in terms of doing animal model training. Is that something we need to look into? Of course, there's the whole cost of it and the ethics of involving live animals. So just, I would like your opinion and comments on this.
One final comments.
Yeah, of course, you don't have patients to train, training on lab, dry lab, animal lab is useful. Animal lab is most similar to human, but it's most difficult to prepare. So, in the past we would we have to create an obstructed duct, so we have to get the animal in and surgically ligate the papilla or something, and then create a distended duct or puncture, and then it's very similar to real life, but it's very cumbersome. But of course, if you have these chances, it's useful.
Yeah, I think there is a number of prototypes which are sometimes already in development, and we know about them and we've been involved with them, and they are known for 10 years, but they are still not on the market. When you can minimize it to a certain extent. We do also a lot of procedures freestyle, so we don't have but so some processes are already minimized and reduced in terms of number of accessories we are using. But there is also different corporate intentions which are in this. So some devices are coming slower. Now we are facing withdrawal from the market, hopefully temporary, of devices which we were relying last 15 years over. So it disrupts what we already achieved. So it's very important. Anthony already commented on the models. Yeah, I think there was a very good comment that mutual assistance. It's very good for the training. We use it also in Japan. It's a standard model how you achieve the feeling, the exchange of the wires. It's nursing staff depends where they don't like to see because you're stealing their job, but it's very good to get involved, get that immersive experience, and get that feeling. And as for that, Mohan was shouting at you. Don't worry, he asked me for favor and still shouted at me, so I was not even his fellow.
So, I think all these are very good perspectives. But I guess ultimately, no doubt, you mentioned the learning curve being steep, right? But I think it's maybe not that steep. Just they don't have enough case volume. You don't have enough experts to teach you. Unlike let's say regular EUS, regular ERCP, right? Because you realize, although we don't want to talk about numbers, but you realize that the numbers you need to get proficiency, competency for ERCP, for EUS, even EUS imaging is much higher than the numbers you need to be comfortable with C06 drainage, right? Or HES. That one just see a function, you get the right treatment and it can be done. So ultimately, I think the cornerstone is ultimately a solid foundation in your ERCP, in your EUS and EUS-FNA. And I think what Clement shared is also important in the sense that sometimes when we do teaching, we actually should break down what we teach into different components and into modules, so that people, so a person need not do the entire procedure. They just learn one module and then they master that, and then they can put things together. And towards the end, they just put everything together and they go through the whole procedure. So at the start, it's not possible for someone to do the case successfully from start to end. But if you don't even let the person try a little bit of one part, he really have difficulty. He'll take a long time to master the whole thing. But if you allow them to do small parts each time, I think it can really help to simplify the learning experience. So I think with this, we need to stop our discussion, and maybe so I think we'll also stop the online transmission right now. I want to thank everyone for coming, and importantly, I'd like to thank our faculty, both international faculty, Anthony. Rusty is a bit half international, half local, and then also our other local faculty, Jun Liang, and Andrew, and of course, importantly, our sponsors, Olympus, Teh Wong, Microtech, and MedicPro, which actually distributes the Teh Wong and Microtech products. And this is actually totally organized by AEG and CGH. So maybe we just have a group picture before we break for lunch. We come back about